The second stage we decided. No, sir, it's not. So, so firstly, it is the evaluation of the child. If the between the stages we do we repeat certain investigations like hemoglobin, the cardiorespiratory reserve. The anesthetist also sees if how early we can take him up for the second stage. If the hemodynamically and cardiorespiratory is stable, we take up earlier, say 3 days. If thoracoloplasty in the second stage, sir.
Have you actually measured what is the difference in blood loss and how many times you change the screws and all those things between the two groups?
No, sir. We have not compared, sir. We have not compared the studies between the two groups, but.
So it is just.
No. We have. There are no.
Have you ever changed any screw in 2 stage? Because
yes, in a couple of patients we did have to change it.
So how many times you changed it? Out of 11 cases?
Out of 11 cases, I think in 3 or 4 we did.
And how you decide pre-operatively that, okay, in this kid I'm going to go double stage and in this kid I'm going to go single stage?
So most of the patients,
your retrospective study, so you decided
most of the patients we decided beforehand because of the rigidity of the curve and the age of the patient as well. Because older child, it requires more time of exposure. It needs to more amount of blood loss. And in other patients, we decided interoperate.
Yeah, thank you, Sharvil. So next paper is by Dr. Vatsal Parmar on concept of pedicle vertebral body angle, a morphometric analysis of the angle between the cervical pedicle and vertebral body in subaxial cervical spine for safe insertion of pedicle screws.
Good morning. I'm presenting on the topic, the concept of pedicle vertebral body axis in the insertion of cervical pedicle screw. Introduction: cervical screw insertion is determined by many factors. First is smaller diameter of the cervical pedicle, the proximity to the vital neurovascular structures, and variation in pedicle size. For improving the biomechanical stability and avoid complications, the following points can be taken into consideration. First thing, appropriate entry point. Second would be the angle of the placement. If we see in the axial view, that is a longer screw can be inserted, but when we observe the same thing on the with the intraoperative navigation, that a smaller screw need to be inserted because it would so-called injure the superior end plate. And what things need to be taken into consideration, that should we need a shorter screw, or should we change the entry point, or what if we change the entry point, would we lead to a facet injury or not? The effective diameter that would permit the insertion of the screw of a given size would be much lesser expected before, depending upon the measurements of pedicle height and width. The angle of the insertion assumes the utmost importance in both axial and sagittal plane. So many studies have considered the axial angle, but sagittal placement is not understood completely. Aims and objective to analyze the relationship between the cervical pedicle and the cervical vertebral body in the subaxial cervical spine, to study its importance as well as variation of safe placement of cervical pedicle screw, and to correlate between the cervical lordosis and the change in pedicle vertebral body angle. Materials and method: it was a retrospective radiological study. Out of 50 patients, that is 400 subaxial spine were taken into the inclusion, and subjects were of degenerative cervical spine in a tertiary center between June 2018 and December 2021, and the subjects which were operated from posterior approach were taken into inclusion. Exclusion were cervical tumor, trauma or infection, and subjects operated with anterior or anterior combined with posterior approach were excluded. First thing what we did was on radiographs, lateral radiographs, cervical lordosis was measured with the Cobb's method between C2 to C7, and whether it was cervical lordosis or cervical kyphosis were differentiated from it. Second thing, a planar probe. After taking intraoperative CT scan and navigation, a planar probe was kept in such a way that in the axial view it would go with the direction of the pedicle, and on that particular direction on the sagittal view, the angle between the the vertebral body and the angle between the pedicle were calculated, and they were differentiated into 3 groups, that is depending upon the angle: grade 1 0 to 20 degree, grade 2 21 to 40 degree, grade 3 40 more than 40 degrees. And what in 50 patients, what we found was that the mean age was 55. There were 15 females and 35 males, and the mean cervical angle was 5.46 plus or minus 1.6 degree. The amazing thing what we found was that there was a decreasing trend from C3 to C6. That is, in C3 it was 41.06 and in C6 it was 16.62. So as we move more distally, more caudal, the vertebral pedicle vertebral body angle decreased. Second thing what we found was in C3 there were no grade 1, only grade 3 were more. Similarly, contrary to it, on C6 the grade 3 were much less, and it was a more of a grade 1 in C6 vertebra. Relation between cervical lordosis and PBA, no significant association what we found between the cervical lordosis or kyphosis and pedicle vertebral body angle. And regarding age, it was not clinically significant. Conclusion: the direction of the screw placement on the sagittal planes differ at each level in subaxial cervical spine. PBVA assessment on preoperative images aids in determining the entry point. It indirectly helps in safe placement of cervical pedicle screw 4 levels, and surgical implications of the radiological study are yet to be assessed. Thank you.
Thank you for finishing on. Yeah, Dr. Sandeep.
Nice paper, Vatsal. Just one question.
Yes, sir.
What was the incidence of sclerotic pedicles in the cervical spine in your 400 pedicles that you assessed? And how did you assess the pedicle angle in these sclerotic pedicles?
Actually, what first question, thank you for the question, sir. In adult degenerative scoliosis, there are more chances of the sclerotic pedicles as compared to other rheumatoid or other cases. Out of 400 pedicles what we had assessed, almost 20% had sclerotic pedicles, and the images were transferred to SurgiMap. So in that, there is an option that if we select the 4 borders of the so-called vertebral body or the pedicle, a center line would be demarcated in that, and between the 2 center lines, what we did was that we calculated the angle between the 2 center lines. So it was easy. In case of sclerotic also, we were just able to mark the borders of so-called pedicle or the vertebral body, and center line would be formed in the SurgiMap software, and between the 2 lines we would be able to calculate
so
the
out of this 20% sclerotic pedicles,
yes, sir.
how many pedicles were you able to navigate and actually put in a pedicle screw?
So since the sclerotic pedicles are very difficult to as in there are high chances of breach. In case of sclerotic pedicles, there are more chances of getting away towards the lateral, towards the artery, but there are high incidence of so-called 50% in sclerotic. We were not able to exactly direct the screw on the what trajectory we had planned pre-operatively, sir.
Thank you. Thank you, Vatsal. Now we move on to post-thoracotomy spinal deformity case series, again by Dr. Seth. Sharvin Seth, over to you, please.
So congenital disorders such as congenital heart disease, congenital esophageal atresia, tracheoesophageal fistula, these are the common congenital disorders that we come across, and sometimes it has to be operated, and sometimes in an emergency thing such as tracheoesophageal fistula, because of because of congenital disorders, they also are at a higher risk of developing spine deformities, and there can be associated systemic anomalies. Then thoracotomy is a routinely done procedure for the treatment of these congenital conditions. The hypothesis is that the structural integrity of the thoracic cage is compromised after a thoracotomy procedure. Congenital anomalies such as TEF is a very common thing, and the incidence is around 1 in 3,500 to 4,500 live births. Similarly, congenital heart disease is also a common multiple pathologies that can be present. So the aim of our study was the awareness of thoracotomy as a cause of progressive spinal deformity. After a thorough database search, we included patients who underwent thoracotomy and developed progressive spinal deformity. Clinical evaluation was done on shoulder balance and hump correction, and appropriate radiological measurements were done on X-rays. The results, we had 6 patients, 3 males and 3 females with the average age of 15.5 years. The average pre-op Cobb's angle was 66.4 and a flexibility index of around 25%. The correction achieved was 58.4% and the mean SRS score was 4.49. There were no post-operative complications. So the first case of a 6-year-old female, thoracotomy was done right after birth for a thoracoesophageal fistula. And we can see here that at birth, the thoracoesophageal fistula is present and she was operated for the same. At 1 year time, she started developing a deformity in the upper thoracic spine. And the deformity gradually progressed at 2 years, 3 years. And we can see in the sequential X-rays. And on the CT scan, we can also see rib fusion that is present on the right side. And at the time of surgery, she was 6 years of age and we operated her for the same. And we can also see the thoracotomy scar that is present. Similarly, the second case of a 23-year-old male where thoracotomy was done after birth. And we can see again the rib fusion we can see on the CT scan as well as on the X-ray. And the thoracotomy scar is also present. A similar case of a 12-year-old female where thoracotomy was done in early childhood. The rib fusion is again seen again on the left side. A 17-year-old male where he developed progressive spinal deformity and was operated for the same. There's a case of a 13-year-old female who was operated at birth for diaphragmatic hernia. And at birth, we can see the spine has a good alignment, but gradually it has progressed to a lumbar curve at 13 years of age. That is when she presented. And we operated her for the same. And at five years follow-up, she's doing good. Similarly, a 22-year-old male who had operated for patent ductus arteriosus at 9 months of age, and he presented to us with a progressive spinal deformity. He also had undergone surgery for the deformity correction. So patients with congenital disorders are at a higher risk of spine deformity as compared to others, and thoracotomy compromises the structural integrity of the chest wall. If we add sternotomy to it, it acts as a double hit. Thoracotomy also leads to pleural scarring, which is termed as pleural scoliosis. And thoracotomy closure by rib suturing, it leads to rib fusion and imbalanced rib cage growth, which leads to scoliosis. This is a paper in the Journal of Pediatric Surgery. They did a retrospective study of 106 patients operated for esophageal atresia with or without TEF. 53 patients of them developed scoliosis, out of which 4 required surgery, and they thought that right-sided thoracotomy is a risk factor for progressive spinal deformity. Similarly, other papers where we can see they have been operated for thoracotomy for various congenital disorders. Mostly it is esophageal atresia and TEF, and the incidence varied from 3 to 67% in one paper. In one it was 26%, and in another one 8 patients. They included only patients that developed progressive spinal deformity after thoracotomy. So in conclusion, the curves can be misleading because of age of presentation, which we can think that it is adolescent. And because of the curve magnitude, we think we can achieve a greater correction as in AIS. But because of rib fusion and other associated vertebral anomalies, we have to investigate, we have to ask for a thorough history as well. Thank you.
Thank you, Dr. Seth. I think your paper open for discussion.
Thoracotomy have been done since many years, but in all those cases we never had any scoliosis. So do you think that conclusion that thoracotomy leading to scoliosis, I think there is a doubt. Why? Because these patients who are going to develop scoliosis otherwise also, even adolescent, there is a genetic thing which is underlying, and these tissues are not normal. So I don't think it is wise to conclude that it is the thoracotomy which has led to the scoliosis, because thoracotomy is done since ages, but all those patients, they don't develop.
Yes,
Isn't it?
agreed, sir.
Thank you, sir.
Thank you.
So next paper is by Dr. Udit Patel, post discectomy pyogenic lumbar discitis review.
Thank you. I'm Hitesh. I would like to acknowledge my colleague, Dr. Udit Patel, who is not present here today, and I'm presenting on his behalf. So, as we know that post-discectomy discitis is the most annoying complications in any surgeon's professional career. And therefore, optimal management is often controversial because as a surgeon, we are first in the denial phase to accept. And therefore, the aim of this literature review is to see incidences, causes, and management strategies in post-discectomy discitis. For our research, we have done extensive search on Google Scholar, Medline, and PubMed, and went through the abstract of 584 papers with complete review of 38 articles. After excluding some articles, but lumbar discectomy, we have ended up in reviewing 21 articles for this review research. In our research, we have three categories: patient related. Coming to the results, that overall incidence of post discectomy lumbar discitis was 0.94%, means around 1% of the patients operated for lumbar discectomy can develop pyogenic discitis, which is not related with any kind of surgical approach, whether it's open, microscopic, endoscopic. Patients related factors where preoperative diabetes was the most common in 26% of the cases. Other important factors were obesity, smoking, alcoholism, DVT, varicose veins, urinary and abdominal infective or inflammatory pathologies. Thus, it is imperative to search, treat, and control these possible causes before proceeding for a simple surgery. Reviewing the causative organisms, Staph aureus was found in approximately 20% of the cases. However, some of the reports suggest up to 50% of the infections might be due to Staph aureus. Other organisms were gram-negative associated in associated urinary or abdominal conditions and anaerobic organisms as well. Most clinical feature is severe low back pain with or without fever and rigor. However, other neurological complications depend upon duration and extent of the disease and cord compression. Investigating these cases shows increased white cell count with CRP and ESR in most of the cases. Report showed 100% sensitivity and 97% specificity using CRP. However, it had only 31% of positive predictive value. Therefore, other investigation methods must be considered in such cases. MRI is the other important radiological investigations, as X-ray often do not detect early stages. Sensitivity and specificity for MRI is 93 and 97% respectively, with positive predictive value is around 95%. So MRI should be considered whenever you suspect infection. Literature often divided into conservative versus surgical management, with approximately 56% and 44% cases respectively. Conservative management methods emphasize on CT guided biopsy, culture and sensitivity, followed by at least 3 to 6 weeks of antibiotic with regular monitoring of blood parameters and clinical improvement. Management of post-operative lumbar discitis focuses on thorough debridement of disc along with the fixation methods with or without TLIF procedure. Therefore, fusion is the mainstay on surgical management in such cases. This slide shows the articles where they have included the cases and type of management practices, with 40% of excellent result and 56% good results, means 96% having successful results. However, 4% cases may not have successful outcome. So in conclusion, I would like to say that to prevent post-discectomy discitis, minimizing preoperative risk factors, administering pre and post-operative antibiotics in appropriate doses are critical. Diagnosis should be made with thorough clinical acumen, blood investigations, and MRI, various modalities of conservative management or surgical management patients' clinical outcome. Thank you.
Thank you, Hitesh. Now, yeah, Subir bhai.
As far as spine is concerned, the role of procalcitonin and spinal infection has been debated. What is the current state of literature on procalcitonin in spinal infections?
I have not studied that part in this literature review, so I may not be able to answer it properly.
Yeah, but
If anybody
in
can
my experience,
focus,
I have not seen any correlation with procalcitonin and discitis. Like procalcitonin will be normal and
Last
patient would
I
have
read,
discitis.
it said that it is not sensitive for spinal infections. But if you ever involve an ID guy, they always send procalcitonin.
ID and ICU guy,
So
they always
I
do
really have
procalcitonin.
my doubts whether they don't read about procalcitonin and spine, or is there some new
I
information
think
that
it
we
is-
are missing?
I think it is highly sensitive. That's what my experience is in with ICU.
No, it is
guys.
highly sensitive for non-spinal infections.
Possible.
Blood infection, basically sepsis.
Sepsis. But sir, whatever I have seen in ICU, the patient who is in ICU and developing fever, including post-operative spine patients or any other, they always go for procalcitonin.
Yeah, but good number of
Exactly.
patients would not have fever. They would
Yeah,
just come
that's
with a
true.
local pain,
That's
right?
I think
Yeah.
Not for overt infection
Overt.
where you need this.
Yeah, I think the best answer for that would be have the meeting with ID people. That's what we do. We have the Zoom meeting, and then we have them on board, and we ask the question. We ask them to present. Thank you, Hitesh. Let's move to any. Rohan, you wanted to ask? Sorry, Hitesh. Yeah, Rohan, please. You are loud enough. You speak.
So in this review, do you have any paper which says that as far as surgical management is concerned, where you have percutaneous procedures where you just address the instability in the post discitis patient and just take culture sensitive, or just take biopsy and then
That comes into the conservative management plan. Just take-
biopsy and stabilization both?
not stabilization is definitely surgical.
Yeah.
But whatever review we have done, I think it favors fixation with debridement of the disc tissue.
Okay.
Not just the biopsy.
So this was something I think that Anil would also agree. What we have been doing is we have just been taking biopsy via the transforaminal route and percutaneously stabilizing post-discectomy patients.
I think Dr. Rakesh has also the similar experiences using transforaminal.
Transforaminal biopsy
Yeah.
plus debridement. You irrigate a lot of saline, right?
Yeah,
So it
or
is-
you can, I think Dr. Krishnan had one paper where he's going endoscopically and just
Yeah, so
harvesting
that's what I'm
biopsy
saying.
and
So
then
it is-
stabilizing.
endoscopic
basically-
transforaminal.
Yeah.
It's
So-
the same route actually.
So, but that we use in patients who has got preserved end plates.
Yeah.
We don't want to fuse early discitis.
Yeah.
We select the cases for transforaminal disc debridement.
Yeah.
And if
So we just
so
go
it
one
is-
step ahead and stabilize as well to take care of.
So my cases were not all surgical fusion. Majority of people preferred surgical fusion, but yes, surgical fusion with debridement. That's why I written with or without fusion. Right.
Thank you. I think let's move to the next paper. It is on the safe Ponti osteotomy with ultrasonic bone scalpel is quick and neat by Dr. Vikrant Chauhan. Over to you, Vikrant.
Good morning, teachers. I am here to present the paper on the safe Ponti's osteotomy with ultrasonic bone scalpel. It's quick and neat. The Ponti's osteotomy in 1987, Albert Ponti described Ponti's osteotomy for correction of Showman's disease. Since then, Ponti's osteotomy has proven its worth in correction of different spinal deformity. Ponti's osteotomy includes wide resection of facet joints with capsule, lamina, and the intervening soft tissue. Traditional tools such as Carrison rongers, high-speed drill, rotating burrs have been used for creation of osteotomy, but carries their own intrinsic risk like neural dural tears, loss of bone graft, intraoperative blood loss, thus increasing the overall surgical time. The ultrasonic bone resection may be novel in spine surgeries, but it has been used by decades by oral maxillofacial surgeon. Ultrasonic bone scalpel or Mesonix, which we use at Stavia, is a piezoelectric device, as you can see, with a blade and a jet nozzle. And our experience with this device in multiple spine pathologies have been published in multiple peer-reviewed journals. We conducted an observational study at Stavia on the use of ultrasonic bone scalpel for the creation of Ponti's osteotomy. For the primary assessment of first, time taken to perform osteotomy, and second, the intraoperative epidural bleeders which require intervention. The inclusion criteria was all the patient who underwent Ponti's osteotomy for spinal deformities with ultrasonic bone scalpel from 2013 to 2022, and patient with spinal deformity in elderly population was excluded. Various intraoperative variables were recorded like number of Ponti's osteotomy segment created, time taken, number of epidural bleeding points which require cauterization or packing, intraoperative dural tear, signal loss on intraoperative neuromonitoring. As we can see in this video demonstration, a straight on an oblique osteotomy cut is made which remove the lamina along with facet joint, which creates gills fragment like structure as in lytic listhesis, and these fragments can be plucked out. On the left side of the image, we can see the osteotomy cuts being made, and on the right side, the Ponti's segments are removed with clean margins. A total of 113 patients with spinal deformity due to various pathologies underwent Ponti's osteotomy with the use of ultrasonic bone scalpel. The important finding in our result was that average time to osteotomize one segment was 3 to 3.5 minutes, and average epidural bleeding point which required intervention was 1 in every third or fourth Ponti's segment created. No dural leak or signal loss in IUNM was noted. So we can say that ultrasonic bone scalpel is an advanced tool which provide a wider corridor for safety due to tissue selectivity, and it avoids any entrapment of tissue. It has a very precise cutting. It reduces the intraoperative bleeding, and there is no impedance in the vision of the primary surgeon as there is no hand for irrigator syringe, and there is minimal bone debris, and we get a substantial amount of in-toto graft. All these things reduces the overall surgical time. As a result of a study shows significant positive result, ultrasonic bone scalpel can be a part of today's spine surgeon armamentarium who are doing deformity correction. Thank you.
Yeah, thank you. Paper is open for discussion. Questions? Yeah.
So nice paper. Have you compared this with the standard burr that we use in a Ponti's osteotomy?
So it was an observational study on the use of ultrasonic bone scalpel. We are presently have not compared with the use of rotating burrs or.
You are using the Mesonic. Yes, sir. What is the difference between this and Mesonic?
No, sir, this is the Mesonic only, sir.
This is Mesonic.
The Mesonic only.
Yes.
Sir, we compared, shall I share? We had 3 or 4 companies, they make it. And we are planning to buy one more, the gadget. So we compared all the 3. So this is spine surgeon and orthopedic surgeon tool. The others are neurosurgeon and the dental tool. They are slow. They take time to cut. While this one is fast and it does not take a lot of time to cut. So that's the major difference, the speed. And usually they are made for the dentist. Well, this one is made for us.
So there was no dural tear.
Yeah, thank you.
Thank you.
So next paper is by Dr. Mani Anand on posterior approach single level apical spinal osteotomy in pediatric patients in severe rigid kyphoscoliosis. Long-term clinical and radiological outcomes.
That is not open. Yes, yes.
Good morning, Chairperson. Title: Posterior approach single level apical spinal osteotomy in pediatric patients for severe rigid kyphoscoliosis, long-term clinical and radiological outcomes. Spinal osteotomy in pediatric patients is challenging due to various factors, including poor bone quality, rapid progression of the deformity, suboptimal implant purchase. Surgical correction of kyphoscoliosis can be achieved Combined posterior and anterior approach, posterior only approach, like closing wedge osteotomy, SPO, PSO, and VCR. Modified VCR, closing opening wedge osteotomy. Our study was a retrospective case series aimed at to evaluate functional, neurological, and radiological outcomes through posterior approach only. Total 32 patients were selected at a single institution by a single surgeon. Inclusion criteria were age less than 14 years with rigid thoracic, thoracolumbar, and lumbar kyphosis with greater than 70 degree with or without neurological deficit, with or without scoliosis with minimum 2 years of follow-up. Exclusion criteria, cervical or lumbosacral kyphosis were excluded. Data were collected in the form of demographic data like age, gender, and etiology, pain score through VAS, functional score through ODI, neurological status through Frankel grading, radiological parameters in the form of kyphosis angle, levels inside, perioperative data in the form of operative time, blood loss, dural leak, hospital stay were collected. Full length AP and lateral radiographs were collected. Level of the apical vertebra, SBA, and curve angle for scoliosis and kyphosis were documented. Bone graft fusion was assessed through Bidwell's radiological criteria, and follow-up was done at 1 month, 3 months, 6 months, 12 months, and 24 months. Surgical procedure, midline posterior approach was utilized with subperiosteal dissection with free pedicle screws were inserted using freehand technique, and facetectomy was done at the level to be fused. Intraoperative neuromonitoring was done. Resection carried out at the apex of the deformity, and width of the osteotomy was broader on the convex side and posteriorly for correction of both sagittal and coronal plane deformities simultaneously. The transverse process and rib heads were removed to allow complete dissection of lateral wall of the vertebral body. Nerve roots in the thoracic region were sacrificed if necessary. Vertebral body resection was performed piecemeal through rongers, burr, and curettes. Dissection was carried out until the anterior wall was removed, keeping the ALL and medial wall of the pedicle and posterior wall of the vertebral body intact. A temporary rod was fixed on the ipsilateral side, and similar procedure was repeated on the contralateral side. At the end of this process, a bony cell remained around the dural sac circumferentially. At this stage, the posterior vertebral wall anterior to the dural sac and medial pedicle wall and lamina on the dorsal aspect of the dura were removed. Deformity correction was attempted by closure of the osteotomy with sequential rod. Gradual correction of the kyphosis angle was attempted at every sequence of rod bending. In correcting the scoliosis, compression and shortening was done more on the convex side and was asymmetrical. The end point of column shortening in our series was direct visualization of dural buckling and MEP SCCP signal channel loss or more than 50 mm of closing of the wedge on the convex side at the posterior face of the osteotomy. Posterior fusion were performed at all instrumented levels. The number of levels to fuse was decided interoperatively depending on the extent of the correction achieved and the gap present anteriorly after osteotomy. If the gap was less than 10 mm and sufficient correction was achieved, with bone-on-bone contact after closure of osteotomy, only 2 levels or above and below were fused, sometimes extended to 3 levels above and below. Anteriorly, if the residual bony defect after closing osteotomy was less than 10 mm, auto cancellous bone graft was placed, and if the anterior graft was more than 10 mm, a titanium mesh case filled with bone graft was placed. This is a case preoperatively and postoperatively of a 14-year-old male operated for rigid kyphosis. Results: 6 patients were lost to the follow-up. So 26 patients were available for the data collection with the male-female ratio 18:8 with different etiology. Osteotomy was done right from T5 to TL3 with maximum osteotomy was done below T11 or below. VASO score improved preoperatively from 5.85 to 3.15 postoperatively. ODI score improved from 56 to 19. Mean number of levels fused were 5.69. Mean operative time was 243 minutes and mean blood loss was 337 ml. Radiological outcome, kyphosis angle increased perioperatively from 96 to 30 degree. At the final follow-up, it was 34. So there was a loss of correction of about 4 degree. And scoliosis, it was 52. Postoperatively, it was 15. And final follow-up, it was 19 with a loss of correction of 3 degree. Complication, there were dural tear in 2 patients which healed, and implant failure was noted in 1 patient for which revision surgery was done. Superficial wound infection was noted in 1 patient which healed automatically. And neurological deficit was reported in 3 patients, 3 recovered, and there was persistent in 1 case. To conclude, the technique can be performed in small channel with good clinical and radiological agents with satisfactory correction rates. Although technically demanding, can be reliably executed by a skilled spine surgeons. Thank you.
Yeah, thank you. Dr. Sandeep, please.
So nice paper. What was your indication for choosing a particular tricolumn osteotomy on preoperative parameters? Did you choose VCR in all cases or PSO in all cases? So what were your clinico-radiological parameters for choosing a particular osteotomy in this subset of patients?
Sir, the level which were most sorry, wait.
Okay, next.
Yes, sir.
Yeah, thank you.
Yes, there are 4 cases of neurological deficit. Is there any correlation which segment of osteotomy has more correlation to post-operative neurodeficit? Is there any correlation?
Yeah, there were some cases in which osteotomy is done at L1 level. So there is a cardiac vena and conus. So in those cases, neurological deficits were reported.
What I know, in the upper thoracic region, when we do osteotomy, there are higher chances of neurological deficit. Any tips to prevent particular?
So there was a neuromonitoring being done, but in cases where there was acute column shortening, in those cases, transient neurological worsening was reported, which later on reversed.
Yeah.
Okay, yeah, we can discuss later.
Yeah.
We move on to next paper by Dr. KU Ragbari. This is the last paper of this session. Retrospective match comparison study of non-fusion anterior scoliosis correction versus posterior spinal fusion for Lanke-5 AIS curves in skeletally mature children, clinico-radiological outcome with 2 years follow-up. Yes.
Today I'm going to present the work with Hospital Chennai under Dr. SAJAN HEGDE. Has there been a paradigm shift in management of adolescent idiopathic scoliosis? Yeah, so has there been a paradigm shift in the management of adolescent idiopathic scoliosis? The anterior approaches dropped steadily by the last quartile, with posterior only approaches rising from 29% in the first quartile to 96% in the last. And anterior approaches are again regaining the same prestige which in the 90s it had with the novel non-fusion anterior scoliosis correction technique. This is a case of a 13-year female, post-menarche, riser 4, Sanders 7, TRC close. What are the treatment options available? One will do a posterior spinal fusion, compromising the spinal growth and motion. And other option is the anterior spinal fusion, saving levels, but spinal growth and motion will be adversely affected. This we did at that time. So we are in the 21st century now. Can we have some better options? While time-tested traditional posterior fusion with predictable clinical outcome would have been the gold standard option for our study patients, some studies suggest a decreased spinal growth over the length of fusion construct, decreased range of motion, decreased spinal mobility, adjacent disc degeneration in the long term, back pain in long term with spinal fusion. Non-fusion anterior scoliosis correction is a fusionless treatment option for the management of AIS. Existing clinical literature evaluating non-fusion anterior scoliosis correction have reported safety and efficacy in skeletally immature children. No study has been conducted so far to analyze the functional result acquired as a result of non-fusion anterior scoliosis correction in skeletally mature patients with Lanke-5 AIS and to compare them to function result revealed by posterior spinal fusion. We hypothesize that non-fusion anterior scoliosis correction offers comparable correction to posterior spinal fusion with significant less blood loss, operative time, reduced length of stay, reduced number of instrumented level, and preservation of spine flexibility. The aim of the study was to compare the safety, efficacy, and functional outcomes of non-fusion anterior scoliosis correction and PSF in skeletally mature bone age AIS children with Lenke-5 curve. It's a retrospective study with 38 patients with a minimum follow of 2 years. And 38 consecutive Lenke-5 AIS patients treated by a single surgeon were divided into groups with non-fusion in group A and posterior spinal fusion in group B, and were matched by age, corpse angle, skeletal maturity, and intraoperative and perioperative data. And in the follow-up, we measured Cobb angle, SIS-22 question, perioperative complication. As we see the demographic data, there was no significant difference between the two groups. We see the perioperative data, the duration of surgery and estimated blood loss was significantly less in non-fusion group as compared to posterior spinal fusion. And the average number of instrumented vertebrae were also less in group A as compared to group B. The length of stay was significantly low in non-fusion group as compared to fusion group. As we look at the radiological measurement, both the group has similar correction. As preoperative and postoperative Cobb angles, they were similar at 2 years follow-up. As we look at the SIS-22 questionnaire, both groups had improvement in their respective group. However, if we compare the pain, functional activity, and body image domain between group A and group B, it has significantly improved in non-fusion group as compared to group B. This is a serial radiograph of a 14-year girl with Sanders 7 and riser 4 showing pre-op thoracal lumbar curve of D10 to L3 of 43 degree, left bending 20 degree, traction of 11 degree, first erect of 12 degree, and 2 year follow-up 11.3 degree. Similarly, a girl treated earlier in 2016 with a riser 5 and Sanders 7 with posterior spinal fusion. There are literature suggesting that global spinal range of motion was significantly reduced as a result of anterior and posterior spinal fusion. The flexor and extensor muscle endurances required as a result of non-fusion procedure were recorded to be significantly superior than that acquired as a result of posterior spinal fusion. And non-fusion differs from traditional VBT in that it is not just merely tensioning the cord, but it relies more on intraoperative translational, derotational maneuvers and maximum correction at the time of surgery in skeletally mature patients. There are literature suggesting that it is quite successful in skeletally mature children, and it offers promising curve correction and stabilization of curve progression in skeletally mature children with low risk of complication with preservation of spinal mobility and disc health. We have limitation, it's a small sample size and follow-up duration of non-fusion group and a posterior spinal match group were 2 years. It is simply because this technique is novel and it is emerging, and we have not objectively measured the spinal range of motion. We conclude that it does not show significant difference in PSF in terms of COP correction and SRS scores, but it has significant reduced blood loss, operative time, reduced length of stay, and fewer instrumented levels while preserving flexibility. These are my references. Thank you.
Thank you. I think one quick question, if anybody want to.
No, sir. We have not compared, and we didn't have any significant loss of correction in non-fusion group except 2 or 3 degrees. If it was at 18 degree, it might have turned to 20, but it did not. We did not have any significant loss of correction in the non-fusion group. Sorry, sir, I didn't get you. Yeah. No, sir, we didn't have any complication. No tether breakage also. Yeah, definitely, sir.
Sure.
It's on the serial radial X-ray, sir, there will be an intersegmental, the screw angle will change. And based on the literature published in the Western journals, they say that if it is more than 5 degrees, then you have to evaluate further with CT scan because it's not going to see on X-ray. So we didn't have any such incidents till date.
I think.
So regular instrumented level, no, sir. No, sir. It's end to end.
Let us discuss, in the coffee time, please. I think we are 10 minutes late. Sorry, Ajay. Sorry, Subir bhai. Sorry. Let us discuss in the coffee time.
Oh.
Thank you. We are 10 minutes late, so we just want to catch up with the time. Thank you.
Thank you, everyone. So now we are going on to the next session, that is on adult spine deformities. I would like to invite the panelists, doctors, Dr. SAJAN HEGDE sir, Dr. APPAJI KRISHNAN sir, Dr. GURURAJ sir, Dr. Thadadra sir, Dr. Ajay Krishnan sir, and Dr. Danish Patel sir. And would invite Dr. Devanand sir to give his talk on rationale and management and challenges in management of. Yeah.
A very good morning to everyone. I'm Dr. Ravi Ranjan. I'll be presenting on behalf of Devanand sir, and we are discussing the rationale and challenges in management of adult spine deformities. As per definition, it's a term which encompasses developmental, progressive, and degenerative conditions that contribute to an altered three-dimensional structure of the human spine. We classify into type 1, which is de novo. Type 2 is untreated adolescent scoliosis that has progressed into adulthood, which is rarer, but it is essential to identify since it's a different pathology. And type 3, which is secondary to previous surgery, trauma, or metabolic bone disease. The rationale for treatment in adult spine deformities, as unlike the adolescent, is pain, claudication, and less commonly neurological deficit. Deformity per se, an indication for surgery is only in cases when degree of curve is more than 30 degree, or there is olesthesis or listhesis more than 3 mm. There are separate challenges. This age group, since we are dealing with a different age group, and since the indication or rationale of surgery or more common presentation is pain, it is identifying the pain generator, which is a challenge. Back pain, which may be because of discogenic or the instability catch, or even multisegmental facet degeneration. And in some cases, it's the postural imbalance due to coronal or SAG planes. Leg pain may be attributed to facet joint or ligamentum flavum hypertrophy or foraminal narrowing because of vertebral rotatory subluxation, or even reduction in interpedicular distance due to at the concavity of the curve. These same things can present with neurological claudication as well. The challenge increases because we are dealing with an elderly age group with multiple associated comorbidities, and the risk of medical and surgical complications as reported in literature may be from 45 to as high as 81%. Osteoporosis poses another challenge since the incidence of osteoporosis in patients above 50 and in women can go up to 51%. And in this group, the fusion rate is as low as 56%, leading to iatrogenic instability and fracture following surgery. Challenges related to the approach, posterior approach, since it's a long approach, would lead to higher blood loss as well as an increased infection rate. Anterior surgery is unfamiliar to the few surgeons, and there is calcification of great vessels, which is seen. MIS decompression can be done in selective cases. However, some cases need direct decompression as well as bilateral decompression is required. Anterior approach, although may lead to a better correction, is not shown to lead to any improved pulmonary function after surgery. Another debate and challenge is about how many segments to fuse, whether a short segment fixation or a longer segment fixation is better. Short fusion is usually used to stabilize curves with significant apical rotation when translation or listhesis is more than 3 mm. However, in cases with symptomatic coronal or sagittal imbalance, long fusions would be required. As shown by Glassman et al., the positive sagittal balance is the single biggest predictor of clinical symptoms in adult deformity. Proximal junction kyphosis, which is defined as Cobb angle more than 10 degree as compared to preoperative measurement can go up to 61% in some literature. However, thankfully, the incidence of PJK requiring surgery is almost 4%. Pseudoarthrosis and infection is a common cause for repeated surgery even after long term in cases in patients with adult degenerative scoliosis, and in fact 21% of repeat revision surgery is because of pseudoarthrosis and infection. So in the next 1 hour with the panelists, we'll be knowing how to overcome these challenges. Thank you.
Hello, I would request Ranjith, the case jockey, the moderator here, please.
A very good morning to all, and thank you, Dr. Neeraj Vasavada and team for this invitation. So thank you, Dr. Raviranjan Rai. That was, I think I have no take-home slide. He has given all the message. With this excellent August panel, let us start with the case discussions. Can you have the projection on? So how many of you among all of you at least operate one adult deformity in 6 months? Can I have a show of hands? Wow. Right. How many operate more than 12 in a year? How many have less than 30% complications? Wow. Excellent. So that means we have got one very safe surgeon. So let us go with this. So this was a 7th. By the way, to the audience, is there any cutoff age after which you don't operate adult deformity? You say no to it. Or what is the cutoff age which you have before you say no to surgery? I will have the August panel's opinion later. From the audience, 65, 70, 75, 80, when you say no, now no surgery. Nothing. So no upper limit. Good. So this was a 78-year-old male, hypertensive diabetic. He had back pain for a couple of years, severe leg pain, and the back and leg pain was worsening over time. It was equally severe. And he had, since last 6 to 7 years, he had noticed a deformity of his lower back. And presently, he was disabled by his significant leg pain and claudication. He stands with a list, a forward bent. The range of movement was restricted with pain and spasm. There was diffuse tenderness in the lower lumbar spine, and there was a kind of left lower lumbar region paraspinal fullness because of the deformity, obviously. Neuro exam, he had a left-sided foot drop with grade 2 T-band. Cervical spine, rest of it was normal. So this was it, the way he was standing, stoop forward, list to the right with a forward bend attitude. And all the regular things was done. And the foot drop was present when he came to us for almost 7 months. 7 months since onset. And that is when he sought medical attention. These were his X-rays. I know nobody would go forward without having any further images. So with this, let me start with Dr. SAJAN HEGDE, sir. So with this X-ray, what are your concerns? This is standing AP and lateral X-ray. Mic, sir.
My concern in this particular elderly gentleman is not his deformity. It is disability of his deficit. And I think I would not comment till we have all the workup with us.
So these were the attempted bending X-rays. And these were the full-length standing X-rays.
Yes, definitely his parameters, if you were to, I don't know, have you assessed his lumbar lordosis, PI, pelvic tilt and all that?
Yeah. So
I guess you will have that in one of
Yeah, I've not put it up, but naturally he was kyphotic in the lumbar spine. The PA was 30 and the LL was coming to -20.
Yeah. So you do have a patient with, I like to have all the work, his MRI. And in this particular situation, if you do an MRI, you may not get all the information. So what I try to do in these is a CT Milo, where to see if there is a specific block at a particular level, and
Yes,
then
sir.
plan. So he has a foot drop. So we would like to know. So you see, these MRIs often more than help, sometimes confuse because because of the deformation.
Thank you,
So
sir.
I think
Dr. Ajay, do you get the CT Milo done in cases of these difficult deformities to assess the lateral recess and the
No, no.
canal?
As of now, it should be a protocol, but as of now, we are not doing it regular basis except for any revision cases. It is MR myelogram only that guides us through. But definitely, I would agree with sir that it should be a protocol in certain cases.
Dr. Taradra, sir, what is your take in these cases? What will be your decision-making driver? Is it the deformity? Is it the pain, or is it the neurology?
Yeah, I think at this age, mostly main driving is neurology and clinical symptoms, particularly symptoms related to neurology, not only back pain.
So he has foot drop, he has back pain,
That
he has
should be
leg
considered.
pain.
That
It's been
should
a
be
long
considered.
time.
That should be considered. Second thing, there is a 4-5 segmental listhesis is there, something translation is there. I think I also prefer CT in degenerative cases.
So that's a
not
good point.
CT myeloma, I
You
prefer
take into consideration lateral listhesis. Dr. Guru.
Why CT as a trustee? Because in MRI people, they usually take axial cut at the disc level only. They forget about the facet level normally to some part of pedicle or facet. So in the deformed part, even many times I ask, you take axial cut as pedicle level also.
Yeah, so that can be requested. Dr. Guru, what is your take? What will be your decision-making drivers in this?
First of all, if somebody with this kind of X-ray and this kind of clinical picture, he just comes with back pain. So I would not take it really seriously. So because this patient is having foot drop, then I would start looking at his MRI, looking at his X-rays very seriously, because whatever you do, we know that we cannot actually address back pain significantly in this patient. So because he has a foot drop, so I rarely do CT Milos. I mainly base upon my MRIs, but then I talk to my MRI guy what I want, where I want to look. Basically, if you see in the X-rays, there's a significant lateral holisthesis at L4-5. Significant lateral holisthesis at L4-5. And I would also tend to see supine X-rays. And I would also ask the patient, how is his back pain when he lies down? So that actually gives me an idea actually of whether I need to address the deformity or I just need to address his neurological deficits.
Yes, sir.
Another very important history in this type of patient, when decision making long stuck or short segment or whatever decision, turning in the bed, moving the right leg to like this way or getting up from the bed, not only back pain, any particular radicular pain, sometimes neurologically normal, X-ray it looks good, supple rotational instability, that is many times in dynamic X-ray flexion action we cannot pick up. This history, turning in the bed, getting up from the bed, if radicular pain is a very important thing.
Good point.
So,
Dr. Appaji.
Can I just come? Actually, turning in the bed to have radicular pain, it can be because of two reasons. One, it can be SI joint also. So we have to be careful. So we have to maybe we do routinely SI joint blocks blindly in OPDs. And maybe around 50% of the times we are successful in elevating the pain. So you can try that also. Just a comment.
So Dr. Appaji, what do you think is the driver of this deformity? Is it a PI minus, is it a, PI minus LL imbalance, or what do you think is driving this deformity?
The deformity, I feel, is mainly the low back L4, L5, which is resulted in his altered pelvic parameters. And then to compensate for that, L4, L5 is altered his pelvic parameters. He started stooping for the claudication, and then he has developed a less lordosis, and then less kyphosis at the thorax, and he has become a stoop.
So primarily it's a discal pathology, which has led to a cascade of events, and that has led to his deformity, right? So Dr. Danish, when you evaluate these patients, do you want to treat like what Dr. SAJAN mentioned? You want to just treat his foot drop and the back pain, or you want to treat his deformity also? How much importance will you give in treating his deformity prima facie?
Sir, foot drop is in 7 months, I think.
That's right. That's right.
And it is on the left side, right?
That's right.
Okay. So patient has a curve on the right side. So most of this type of patient,
convexity to the left.
So
convexity to the left.
Most of the patient, they have a opposite direction pain. In this case, it is a right-sided and pain is on the left side. So most of it is a lower curve, which is convex on the left side, which is symptomatic in this kind of the patients. So now foot drop is in 7 months. So anyway, we are not going to treat the foot drop. We are just going to treat a pain.
Why not treat the foot drop? It's only 7 months.
Because it is 7 months. If we do decompression, it is almost not going to recover after 7 months of treatment.
Do you? Yeah, partially, not zero. It's
zero. Okay. Second thing,
I would differ. Basically, I think the message shouldn't go like after a 7-month foot drop will not improve. I think we should give all the chance to the patient. We should decompress, and we all have seen whoever is sitting here, it does improve. In some people, it doesn't improve, but then it doesn't mean that we shouldn't give a chance.
no, sir, not for foot drop, but for pain, we just need to do intervention because he has a severe radicular pain also. Second thing, I just want to ask the patient what is the demand of his life, what he wants from this thing.
He wants to be normal.
Yes.
Like anybody.
Yes, yes. So I just want to see the axial cuts also. And if it is a L4-5 disc only culprit neurologically, then I will do only L4-5 decompression.
So this is
Maybe
L4-5 for you.
Yes. So I just need to see other level also, sir. Whether any other level does L4-5. So maybe if all other levels are clear, then I would do selective L4-5 fusion only.
So you will do selective L4-5.
Fusion.
You will choose to ignore the deformity.
Yes, sir. Yes, sir.
Dr. SAJAN, sir, what is your take? Would you choose to ignore the deformity, or will you?
Well, you have not given me all the information, so I hesitate to derive conclusions. But we should look at spinal deformity in a very different way from what the Western population does. And very unlikely this gentleman is bothered about his deformity. And also, to a certain extent, his neurological compression is adding to his deformity. And I would focus on relieving his neurological, that is the pain, and hopefully help his foot drop. I would not look at his deformity.
So what would be your solution to this problem? What would you do for him? What surgery?
I think I see, but again, I want all the information.
What
I really would like to have a dynamic CT myelo.
Okay.
It tells me a lot of stuff, and this is something we have presented internationally and locally. So it would show me exactly where the compression is. You can make all kinds of surmises. You can sit with the radiologist and he will say, okay, this is where the compression is. And more likely as not, you do that decompression, it may not help you. But if you have a CT myelo and a CT, bang, you know exactly where you need to address the issue.
So the CT myelo says it's maximum at L4-5. How will your...
So, and on which side?
Left side.
Why do you want to do a complete laminectomy? You just do the decompression on that side.
So you will do a focal treatment for that level.
Absolutely.
And you will forget the lateral aesthesis. You will ignore the global and sagittal imbalance. What
I would in this particular picture.
You will ignore it. The reason why you want, because he's 78 or because he's not concerned about the deformity?
I don't think this gentleman has come to you for the deformity. He has come for the pain and the deficit.
So you'll just tackle the focal problem. Dr. Ajay Krishnan, what would be your take? Do you think of any, because now we are coming to a focal treatment of a global problem. You want to look just at that particular level where you are very familiar and you do a lot of O-leaves and all that. So will you be tackling just that level, or would you want to do a direct decompression of this particular route?
Yeah, for this patient, just because a deficit is there, that is the worst, that is the indication why I will intervene. Had it been not a deficit, primarily I would have just pushed it and waited and maybe let the patient go rather than intervene itself. That is my first decision. So I look for reasons to defer for surgery in this group of patients. But being a deficit, it is definitely a surgical case. The reason is that it is one-sided already deficit. If say he develops another side, he is completely going to be down. So I need to go in intervene, but I am not at all in I'm not a follower of any of the deformities for the degenerative group of patients. I would do only focal, but a TLIF.
Dr. Guru, do you agree with the opinion?
Yes, I do agree. But then I think, again, it might sound the same thing. We need to discuss with the patient what does he want. Actually, it will lead on to
anybody who comes at that age want to be pain-free, want the recovery of the foot drop, and want to walk straight.
So, see, this wants to walk straight. Whether he says or whether you say, that again matters. So ultimately, if he just wants, he's bothered about his foot drop, then I think I won't do just a decompression. I would do a single level fusion with the decompression, because there was a facetal cyst there. The facets have actually subluxated, and there is a lateral volisthesis. Lateral volisthesis is more dangerous than the anterior listhesis. Correct. Actually, it's more unstable than actually anterior listhesis. So I won't just do a decompression. I would do a local fusion. But with that, I will also address L3-4 here. I would address L3-4 and L4-5, not only L4-5.
Why?
So because if you see the disc angulation, it is precariously angulated. So if you just go and do a L4-5 fusion, then that is going to again go into a lateral listhesis. So, and if you see your MRI in axials, there is some already a kind of LCS going on, and facet again, they're also subluxating at that level. So I would do 2-level fusion in this patient. If I have to do only a short fusion, if he is worried about only his neurological issues. But if he is worried about his deformity also, which I don't think, if he is worried, then the discussion will go in other direction.
But is L3 not the apex? Just go back to the...
So you have come to the conclusion that it is L4-5. And then you say, okay, his MRI shows L3-4 degeneration. He's 78. You're going to see some degeneration. So this is what I call, you get into a bit of quicksand. You want to get out. The simple thing is to do something very limited to give him the relief, rather than, okay, I need to do more. I need to go to that L1-2 level. Then I need to restore all his sagittal parameters. I think that is getting into a quicksand pit. And neither you nor the patient are going to come out very happy about it. So it's good to correct deformity, but you have to have very clear idea where you're correcting, what you're correcting for, and have clear protocols that you should follow. Rather than, okay, I will stabilize L4-5, but I see degeneration in L3-4, I'll go there. What happens if 6 months later he comes at L1-2 or L2-3? So you don't want to go there. So try to find simple solutions in these kind of.
So your simple solution is a single level or a 2-level TLIFs?
No, it's just a decompression.
Not even a. So when you.
But I want that my CT myelo to show that.
Okay.
At that level.
Okay. Unfortunately, I don't have a CT myelo. So do you think that you can decompress that root thoroughly without knocking off the facet well?
Yeah, I can decompress it very well, but probably I will add to an iatrogenic instability by decompressing.
There's already a lateral
That is holesthesis.
The apex is 3,
that is
2,
more than
3
8
disc is
millimeter
tilted,
of
3, 4 is
translation already
tilted.
there.
Yeah, 4 is lateral
for a
translated. So you end up doing a good job for the root. You end up adding insult to injury. You're going to take off more facets, and he's going to walk, and he's further going to add on and he'll worsen over time.
But definitely a carefully planned micro decompression, what Sir is saying, with a shared decision is not a bad decision.
Let me take Dr. Zala's opinion. Sir, what would be your
Because it is
solution for this problem?
clear-cut facets is there on the left side.
What would be your solution for this problem? Because
I missed the last part, but I'll give you my.
the thing was, do you just do a focal decompression at that level, focal fusion?
So I was just discussing that the patient has got 3 problems. One is a back pain, other is a radicular pain, and third is a deficit. So as Guru was counsel that you have to counsel the patient. Most of the time, the patients are worried of pain rather than deficit. So I would, if the patient can accept a little bit of deficit, and if we can remove the pain, then our treatment will be different.
How?
Yeah. So for that, we need, for counseling, they will not be happy by anything. So I'll give a block to L4 and then ask him to walk after the block. If the patient is happy with the deformity and taken over of the pain, then it will be only, that will be an easy procedure, because we just require to, and if the patient is happy with the block for some time, I'll just pull on, because inflammation can be taken care of by these things. But having said that, that will also give me that the patient has got a one local nerve root.
Focal.
Will go for, of course, I do agree with that. I'll go for a single level relief rather than the full deformity.
Okay, so for the postgraduates or the junior fellows, so this, MRI done in supine position and X-ray done in standing gives different picture. So it's a collapsing curve. Now you can see the whole thing has straightened out. So it's very likely that the moment you make the patient prone or you plan for some surgery, it is going to open up very well. So you might have to do a less of a job with respiratory deformity. So for want of time, we'll go ahead. So these were our challenges. So like we discussed that, well, my goal was root decompression and canal clearance, because my primary drive for him was the foot drop and the leg and back pain. I was not really bothered about the deformity. If it corrects, fine, but I want to knock off the entire facets, because I want to make sure that the root decompresses and get him diffuse, which is a challenge at 78 with osteoporosis and long-standing. He was a tobacco user for a long time. And of course, minimize PJK if he lives long enough. So this was our plan: 4-5, 5%, 3-4 total facectomy. Take out remove whatever comes in the way of the root. And of course, I plan to go to the ileum, and those days we were using this is 2015. So the proximal junctional cement and all those things. So we did all this, went ahead, did this, and this was his post-op correction. And surprisingly, after 3 months, he had a complete recovery of his foot drop, as Dr. Guru predicted. And I still have a follow-up on him. He's still alive. He keeps in touch. So this is it. At L5S1, I had planned a TLIF. But if that disc doesn't open more than 6 millimeter, you can put in soft grafts. So I put in soft grafts and did my T10 to S1 and no PJK yet. So we'll go to another case. She was a 55-year-old female. So one was 78, this is 55. Hypertension, diabetes, which is as usual in my part of the world. Back pain and knee pain and leg pain for a long time. Claudication. She had a history of prior surgery 21 years ago. She had undergone a laminectomy at L4-5. 21 years ago for back and leg pain, which she reported that after surgery, the leg pain became better, but the back pain was worse, and she managed to live on with it for all these years. A stout lady, restricted range of movement, diffuse spinal tenderness, neuroexam was great for power. She had severe knee osteoarthritis in 2016 when I saw her. So I told her probably the issue is the knee, go and get your knees done. She got her bilateral knee replacement done and was happy for a while. And she came back in 2018 with worsening back and leg pain, progressive worsening of knee buckling while she was walking, and these were her X-rays then. So it is the other spectrum of the pathology. Not so oldish patient, female, post-laminectomy listhesis with rotary component with no deficit, significant back and leg pain. These were the regular things, all that. And these were at MRI. So, Dr. Ajay.
Yeah.
What are your concerns? And
can you go to the next slides? So this is a typical deformity presenting with more aggravation now, and there is a scoliotic component with a completely settled disc at probably L4-5, which may not be contributing to any stenosis. So with the lateral olisthesis which is there, I would definitely go in for intervention looking to the disability which is there. I would just go back to the disability part of it. The disability what you are showing is objectively not quantified, or you were saying everything aggravated. So it is the knee buckling what you are talking about is the main thing. Do we need
the
to
main thing was a back and leg pain?
And the leg pain, the radicular root, if you can, it was dermatomal?
It actually it was diffuse. You could not pinpoint it. She used to keep on telling me fleeting. I'm because diabetic, I really cannot pinpoint always where exactly is the offending route. She was saying that I'm finding it difficult to climb the steps, etc. after surgery.
I would still, because I don't see much of a compressive element in this patient, I would definitely get it seconded by a neurophysician or a colleague of mine, whether I am thinking rightly in the direction of the neurological origin of the pain.
So you are not very sure the pain is coming from?
I'm as of now not sure, but definitely a block should be attempted. That would give some guidance about where it is originating from.
Danish, what will be your take on this?
Sir, I just want to see a detailed MRI first. Thoracic, cervical also.
Okay, thoracic is
I just want to rule out because there is a pain on bilateral thing or unilateral?
Bilateral.
Bilateral. It is a buckling bilateral.
Buckling is more on the left.
Okay, so there is a CRC mismatch here, according to me. So I just want to investigate further. I just want to take an opinion of my other colleague also.
Okay, so the neurophysician is cleared for any neurologic issue.
Then bilateral symptoms is not justified by this, I think, things. I just wait
yeah.
and watch. I will give medicines and ask a patient to follow up after 1 month. I just reevaluate again in another time frame, and then I'll decide.
So I sat on for 2 years. I got her knees replaced because I thought that was contributing not to the spine.
Right.
She told the knee pain has gone away, but I'm still not able to walk, and my ADL is affected because of back and leg pain. She's slowly getting chair bound because of the pain.
Okay. So
monoradicular pains and small bucklings and things frequently I have now encountered in Parkinson's, which are strange for me, and also in diabetics. These two cases you find it. So if we can be more communicating with the neurophysicians, definitely I've got good number of patients now.
Dr. Appaji, what will be your evaluation?
In this patient, what Dr. Sarjan says is very important. Get a dynamic CT myelo or a dynamic MRI like Naresh is doing now. You will see a 2-3 which is very cyanotic in dynamic MRI or dynamic myelo.
So you feel that 2-3 is offending feature?
Yes.
Dr. Sarjan, what is your take, sir?
Yeah, again, as Appaji says, we need to have a whole lot of information. Don't rush to intervene unless you're sure what you're intervening for.
So 2-3 because of knee buckling is you expect to have a dynamic stenosis there when you get a CT myelo.
Yeah, but I would like some additional information. Should I be forced to take a decision to look at surgically addressing it? I need some more information.
Apart from the CT myelo, you need what more, sir?
No, the CT myelo.
CT myelo, okay, yeah. CT myelo, sorry, unfortunately, we used to never get it done. Yeah. Because clinical exam and MRI was thought.
People should understand how good it is to help nail down issues.
Yeah, Dr. Thadada, sir, Thadada, what is your takes on this?
Yeah, in this particular case, L2-3 lever, there is definitely left side some compression. It's showing in the foramen, and even in X-ray, if you see, there is a focal kyphosis, I mean concavity on the left side. It is there. Considering to differential other causes related to diabetic or osteoarthritis of knee, as you say, it is already operated. But this part should be considered L2-3.
2-3.
To detect more, dynamic MRI can be done if CT is not available then. X-ray.
So I mean, I have it, but not adding any more information to me. Dr. Guru, what would be your take, your solution for this problem? So let us, want of time, let us.
I think basically because everybody is not can do a dynamic MRI and everybody cannot do a CT myelo. I think simple is to do a NCV, EMG NCVs, and do a dynamic X-rays. And if at all your NCV and your symptoms correlate, then you'll have to take a chance. So this is what I feel. You will have to tell the patient. So we are not completely sure this is what is happening. But then if at all something we have to do is this. And additionally, I would do a root block first before doing anything. So that will give me NCV, and a root block will give me
actually
more
she
ideas.
had a root block first. She had a root block before having this.
May I make a point?
Please, sir.
You mentioned about NCVs. I am kind of disappointed with the outcomes with these studies, and it helps me very little to make up my mind, and often confuses the picture. So I don't like. I do it very rarely. I don't get these.
So I agree, sir, because most of the times you have a foot drop, still it doesn't show anything in NCV. But then if it shows preganglionic lesion at L2-3 and you are in confusion, it helps. I won't say it will help always, but it does confuse you. But if at all your clinico-radiological with NCV is correlating, you are more safer, or you are more convinced yourself what you want to do. So that's all about.
In the audience, do you all get a CT myelode dynamic done prior to such surgeries? Bharat sir.
Presence has made the difference. We have found rarest of the rare diagnosis, and we have deferred surgeries on at least 3 occasions recently. And they were all classic, fitting into the classic surgical. So we have that surgical macho. We can make them better, we can make them. But then, when you have that consultation from the neurophysician, and, he just he's a fresh guy, but then he will say, this is something which is not to touch.
So what were the 3 diagnoses? Which
one was the classic meningioma.
Okay.
Of the brain. So that is something, which you would not, and that you would not operate that patient. And so kind of that, so neurosurgical.
Sorry. Recently, also I am struggling with one case of L2-3. Is operated at 3-4-5. Right side thigh pain. On moment it increase and it disappear. Root block given, radio frequency given, dynamic X-ray taken, stress MRI done. Nothing coming to conclusion. EMG NCV done. With EMG NCV neurophysician consultant, he diagnosed amyotrophic lateral sclerosis.
Yeah, that's.
Yes. Ranjit, can I add?
Yeah, please.
So for the NCV, if you just ask for NCV, both lower limb is not
You
enough.
not get it. Yeah, you should do it.
So you should ask for H and F reflexes to see a preganglionic that is at the root level.
Sample the paraspinal muscles.
Yes.
You always have to ask for that.
So
Yeah, we do
you
that.
have to ask for it. So you just ask for, most of the time we write NCV both lower limbs, which is not adequate. Second thing is, as everybody says, a neurologist opinion, because a chronic diabetic, CIDP, Parkinsonism, starting point of Parkinsonism, where they stoop a little bit forward, and then deformity, and the other thing is demyelination.
Subir bhai, yes.
I had to discuss with the neurophysician that this is the case, this is my dilemma. I want a differentiation. So that neurophysician will do the paraspinal muscles and differentiate whether there is a radiculopathy, there is no radiculopathy. That is how it has been.
So when we have a knee buckling, it's a routine for us to get it, go and see the neurophysician.
See, I want to add, as you say,
knee buckling.
For knee buckling, what say, as a clinical examination tips, because in old aged patients are very vague in their complaint. As you say, right side, left side is more than right side. OE knee is also there. I ask them to step up by each leg. You put one step on the right without touching any objects nearby, and we see how he is struggling. That also gives us indirect any involvement or weakness or this one.
Okay, so
for want of time, just your
so
thought
with
process.
this, we had these because we had the same goals, because we was kind of localized that the deformities, the weaknesses from the 2-3 was 3-4-5 operated, not very oldish, so want to preserve what was possible. So at those 2017, we had just learned this olive thing. And so we thought he's the right kind. Now the pain disappears when she lies down, dynamic pain. So right guy to go and decompass indirectly. But I was not very sure that if I do those days, if I redo my olive, can I decompass the canal very well? No, because the judgment actually is a call. When you do only olives and you get a foramen to open up, or do you stage them? So those days I planned to do 2 stages. First do olive, and it was challenged with an L4-5 rotary component present because of a prior laminectomy. It was one of my first cases where I did a olive for a priorly operated L4-5 laminectomy, that too 21 years ago, means wide laminectomy. And so we did stage 1. We did, for want of time, I'll not go to the olive things. So she was a pretty obese lady. We went ahead, did olive stage 1, and we went through all the routine things. And then after the olive, I did a 3-level olive, and I was not very sure that will the leg pain go away. So this was the X-ray after stage 1. We did a 3-level olive, and then I made her to walk on day 1. And then I asked her critically to tell me about the foraminal symptoms. Was the leg pain better? She was very clear that the leg pain decreased significantly. The VAS came from 10 to 4. And anything less than 5, I take it to be significantly beneficial. So then we plan to go and do posterior percutaneous instrumentation. So went ahead, did that, and this was the ultimate outcome. So from here in the prior case, we went over to here in 2 years' time, and this was the final X-rays of correction. So with this, I think we have 15 minutes. So can I go ahead with the take home or the final summary or any comments from the audience?
You have another case, then you can just rush through it.
No. Only 2. I've kept 1 open and 1 MIS. Yes, sir, please.
I was listening. In some cases, with the symptoms in the lower limb, they were discussing about cervical spondylosis. Somebody found out meningioma. I just wonder, are we forgetting clinical examination? Can't we differentiate between upper and lower motor neuron problem?
So these those cases which Dr. Bharatbhai mentioned definitely is an overlap, because I trust that we all.
No, what I am trying to say is that if we are suspecting upper motor neuron, then we can go for further investigations. If we are sure that it is lower motor neuron, why to discuss about the proximal things?
Yep. Thank you.
Now,
Yes,
your opinion. I would like to.
Yeah. So one thing, what I would like to say is that what happens whenever there is buckling of the knees, immediately it's a red flag.
Yeah.
I start thinking cervical or thoracic myelopathy first. But in those patients, if there is no hyperreflexia and still there is buckling, then you start thinking, is it L2-3 or the quadriceps that is giving way? In that case, there was a foraminal disc on that side, but we didn't have a dynamic either CT or MR or whatever. So there was no dynamization. And in those cases, in EMG and what Guru said would help, because the neuroradiologist can, the neurophysician can differentiate if it is a radiculopathy versus something different. So clinically, if we are not able to identify UMN versus LMN, that is when the dilemma comes. We always do our jerks. And that was actually the theme that I had done when we did this GO at WAPI. How to differentiate, because these are the biggest common mistakes that general orthopedic surgeons make, because they don't use a reflex hammer. But we as spine surgeons always use a reflex hammer to differentiate between UM and LM.
I'll add
sometimes the biggest thing that happens, sir, they used to, they don't. I have seen patients placed on TKR lists because they didn't rule out myelopathy.
I'll add a point. I had references for TLIF for L4, L5 patients coming to me with radicular pain, nothing else, slight stuttering, and you found out they had cervical myelopathy, you did cervical myelopathy. So clinical examination, all of us do, sir. It's not that we don't do, but when we are in a dilemma is what we are discussing.
Sometimes
I am drawing the attention to the importance of clinical examination.
Sir, we agree.
Knee problems, when there are associated knee problems, consider ITK also.
Sir, sir. For this, sir, this patient was TKR operated.
TKR, yeah. We got a
Sir,
TKR done first because this rebuckling, I
Sir,
thought the
sir,
knee was a problem.
sir, the pendulum of the practice has completely changed now. I think we get patients with MRI. We get patients who had 3, 4, 5 consultation, maybe 10 consultations, sir. The practice is completely changed what it used to be. Current situation in the practice is completely changed. And when the more of us, it has become more and more difficult to understand and make it digest to the patient as well, what to accept and what to next, where to stop and where not to stop. It is becoming completely different, sir, as we progress more and more.
So when in doubt, always cross consult. Our policy, when in doubt, always cross consult. Make sure I'm having the right diagnosis. Get neurophysicians or even my colleagues' opinion. Am I thinking right? Call up and ask Guru. This is what I'm thinking. Is it right?
A question, a last question and a comment. How many of us who are operating degenerative scoliosis or things, at 2 years follow-up, you get a complete radiological failure with a clinically stable patient?
Yeah, lot many.
Lot many. So why not accept a radiological failure day one and address the problem what
Sir has mentioned.
Sir
right
has
now.
mentioned.
So yes, doctor. It's a spectrum in continuum. Yes.
Then continuum, right?
Excellent.
So how much do we explain to the patient in adult degen scoli that we are just treating the present symptoms? I don't know 1 year, 2 years, 5 years, what will be.
Just watch on, you'll get the information. So these are the issues. You have claudication, you have back pain, you have deficit, you have deformity and disability. Remember, we are treating the last. We are treating the disability, which is summed up because all the things in the front. So what exactly we're treating? We are treating stenotic symptoms in the majority of these patients. Back pain in few of them. Most of them don't have large curves. They come within 30-degree curves. Lateral listhesis, as Dr. Guru pointed out, is a big thing which you have to really pick it up because that will kill you. All my bad results of focal treatment was because I did not give a lot of importance to lateral listhesis. Flat backs in quite a 50% of them and sagittal imbalance in quite a lot of them. So we have to, when we talk about what Dr. SAJAN was mentioning about lateral canal stenosis, we have to understand that the foramen component has got 2 types. One is an up-down stenosis. Second is a front-back stenosis. A front-back stenosis, which is because of a small pedicle, cannot be attacked by doing an indirect decompression. We have to do a direct decompression there. You'll have to pick it up pre-operative. Extrafemoral sites, sagittal and coronal deformities. So these are the things which contribute to the stenosis in lumbar degenerative scoliosis, which you have to tackle individually, directly or indirectly. Look at this data. 29% of patients with adult deformity have complications, and a lot of them with long fusions. Up to 50% have got complications. So do you really want that in these elderly, frail patients? And these were treated by, SRS trained deformity surgeons, not by anybody off the mill. So to give a pathway to your treatment, this Dr. Mamanini and team from the SRS, from the school study group, the MIS came with this first publication, which said that you look at the SVA and then you decide your curve flexibility and then you go ahead, which was further revised, and they came with the MIS DF2 algorithm, in which a rigid spine or a fused spine was totally differentiated from a partly mobile spine, because it was very important. And that tells you all the standard parameters, the SVA, PT, which Dr. SAJAN was asking, PA-LL mismatch, Cobb angle, and they described which are the patients and what kind of surgery they have to undergo. If you see a lot of these more than 5-level fusions, rigid ones, directly go for open surgery. Don't go mess up with MIS, all that, because they are not the right candidates. So, and again, who are the patients whom you will do a decompression alone? They are people with whom you found an incidental curve. They have minimal or no back pain, less than 6 millimeter lateral listhesis, decent sagittal and coronal imbalance, a Cobb angle less than 20 degrees. Mind you, this is 2010 data. 2010 data. Has it been changed? Well, today, most of us who practice deformity surgery or degenerative spine surgery have developed methods where we try and treat all these things for, endoscopically or microscopically or tubular wise. Just treat the offending root by avoiding a fusion, what Dr. SAJAN and Dr. CHADDHA was mentioning. And who are the patients who have to go for decompression with a small segment fusion? These are stenosis affecting 3 or more levels, smaller COPs, less than 30 degrees, no progression of deformity. It means that you should be having follow-up x-rays or clinical exam findings, no sagittal, remember not coronal, no sagittal malalignment. Adding a limited fusion to the decompressed segments seems to improve the length of symptom-free time. That means they're going to get symptoms back again. You add fusion, it increases your symptom-free time. Not that it will be always be a symptom-free. And what are the concerns? The concerns are what we discussed. If you stop at the apex, say in that first case, we had 3 as the apex, and the stenosis was at 4, 5. If you stop at the apex, will the curve progress? So progression of scoliosis after short segment lumbar fusion surgery is documented at the rate of 3 degrees per year. So which information you should share with the patient? I'll treat your symptom focally right now, but you might have a worse looking X-ray later. So don't be alarmed. You like what he asked, you have got radiography failure with good and happy patients. So that is a concern. You should, it's okay if you tell them prior to surgery that I'm treating your global focal problem with a focal solution, but you have a global deformity, but X-ray will look worse after years. Evidence for limited decompression with limited fusion, EBSJ, which said that less than 30 degree scoliosis patients were good candidates for decompression alone. Now, this is a very vital paper which came from Virginia Lafarge and ISSG. You know, surgeries were done, especially osteotomies, where huge corrections were done at L12, 30 degree kyphotic corrections, pelvic sub PSO or VCR. All these patients had long-term complications. Why? Because we know that there is something known as a harmonious distribution of the lumbar lordosis, meaning 66% of the lordosis should come from L45, L5S1. If you, when you do your sagittal corrections, if you shift your deformity correction to an upper apex, they have increased PJK. So all your lordosis corrections with whatever method you use, ACR or Ponti's osteotomy, whatever release you do, you should get maximum correction at L45 FAS1. If you do it at L12, the so-called PSO safe at L2, you end up with higher PJK. It is proved beyond doubt with enough data. So aggressive correction gets excellent sagittal balance, but rate of 56% reoperation rates because of PJK. 56%. So 50% of your patients will undergo reoperation by you or by somebody else. So this is to be very well taken into consideration that, remember, deformity surgery in adults is not like what doctor asked. It is not a one-time solution to a long-term problem. It is your problem to that solution, that your solution to that problem at that point of time. You are alive, he is alive. Both will face again. Are we missing? Literature is silent in this. Don't we consider the anterior-abdominal wall, the chronic shortening of the abdominal muscles, excessive flexion forces? These are things which are with the patients been stooped and walking forward for years together. You try to a couple of hours, you try to correct the whole thing at one go. Will your abdominal muscle stretch? We have no answer to all the solutions. So then came the concept from the HSSC that can we accept partial corrections? If you talk to senior surgeons, the SKS, etc., who have been doing all these for years together, all don't have PJK, all don't have ASD. You cannot be, no, if it is science, if we are not knowing all this, something should go wrong somewhere. That means there are more to what we understand in these problems. Now, this is an excellent review article of, because whenever you come with a rigid deformity or a deformity which, when you, so for me, the way I take is after clinical exam, if MRI, everything is coming straight, I know that my deformity is not so rigid. I can give a solution by doing posterior column procedures or an OLIF. But the ones which don't correct. So this review article 2022 JBJS classic reviews, the Schwab classification of spinal osteotomies, just to review, type 1 or grade 1 is just where you knock off the inferior facet. Type B or grade 2 is where you take off both the facet, the so-called pontes. Or C is where you take off the pedicle and the body, you preserve the disc. Grade 4 is you take the pedicle and body and one disc. Grade 5, the same with both disc. And grade 6 is when you do the same grade 5 over more than one levels. This is the Schwab classification of osteotomies done for sagittal rebalancing. Look at the evidence. Look at the evidence. 3-column osteotomies should be avoided whenever multiple posterior column osteotomies or anterior interbody fusions can bring about the same change post-operatively. Grade B evidence. Grade B evidence means it's good evidence, not excellent, good evidence, right? So whenever possible, try and avoid 3-column osteotomies because your posterior column procedures or your minimal procedures can bring about the same amount of correction. The level of pedicle subtraction osteotomy should be cautiously selected as it influences the distribution of lumbar lordosis in the upper and lower lordotic lumbar spine, which we discussed some time back. So your correction should happen most at L4-5, L5-S1. Don't do heroic corrections possible at L1, 2, 2, 3, because it does not bring about harmonious distribution of the lumbar lordosis. There is again grade B evidence for that. Now, the third is a technical point. How many of you had got VCR or PSO failures because of rod breakages? 2, 3, yes. So you keep them. I had my failure after 10 years. 10 years, I had my first failure, 10 years. So those days we did not know what is a satellite rod. Do put, put a cage, correct everything. So it is today standard that we have to have 3 at least rods across the segment. Last, anterior column realignment can be alternated to PSOs, and pre-op and post-op lower motor neuron worsening is documented, but they can recover. So the strategy, confess to the patient that whatever you do is not a timeless solution. Set goals in your mind and patient's mind. That's very, very important. Patient should know what to expect, what not to accept. Tell him that part of the pain is what you can alleviate, not the complete pain. Revision is a truth, and he or she should be ready for it. When revision is the question which I and you don't know. If you are successful, you will have it after 10 years. Adult deformity surgery is a challenge. MIS is an attractive option. You can use the ISSC guidelines. Limited surgery has a definite role, and revision is the truth. Thank you, and thank you, my dear excellent panelists. Thank you.
Thank you, Ranjit, and thank you all the panelists. We'll have a quick break for coffee. Please grab your coffee and come back because we want to start much awaited oration from none other than Dr. SAJAN HEGDE. So please grab your coffee and we'll assemble soon. Good afternoon. Good morning. May I invite Dr. Amit Jhala to introduce our next speaker and the oration man, Dr. SAJAN HEGDE. May I invite Dr. Amit Jhala, please?
Hello. Yeah. For those in the spinal fraternity, I think this is too low a thing that I have to introduce the big hero of the spine surgery. Actually, he is one of the pioneers to start the spine surgery in India. And looking back, it is my honor and privilege both to introduce Dr. SAJAN HEGDE, because before 30 years, nearly 30 years, I have been his student, and yet till today I am his student and follow him many of his, and I can see whatever the changes that he has made in his decision making strategies, and is always up to date in his approach to the patient, in his surgical decision makings, and how he does innovations. And these innovations that he brings along, he is, I would say, always 10 years ahead of what we are thinking. That's what I would like to introduce. He has so many feathers in his caps. I don't want to speak about it, but it's my honor and privilege to yet another first in the world or international series that he is going to present today, and that is in the deformity, the anterior teeters. Please, Dr. SAJAN HEGDE. We are very privileged to have you in our annual meeting, and we'll be honored to listen to you.
Thank you, Amit. Thank you very much. Yes, it's been a long journey, actually, isn't it? So I don't see any ladies here. So it's an all gentlemen. So good morning, gentlemen. It gives me great pleasure to be back in my home state. I don't know how many of you know that I've spent my first half of my life in Baroda. And I would like to thank the Spine Association of Gujarat for this invitation. As Amit said, some 30 years back, a very senior and respected member of the ASSI, talking at one of our annual meets, cautioned, and I think rightly so, in adopting new techniques and concepts in a hurry and wait till they become mainstream and more universally accepted. Unfortunately, there is the occasional maverick who will not tread the tried and tested path. And that has been my destiny from the time I decided to pursue my passion in spine surgery some 30 years back. So I will take you on this journey again. And I'm going to introduce a new concept, and that's going to change, I think, the way we look at spinal deformity. And I'm going to talk about non-fusion, not fusing the spine. Orthopedic surgeons, general orthopedic surgeons, more than 60 years back, when Dr. Charnley decided not to fuse the hip, but to restore movement, we are doing this in spinal deformity only now. But I have to start from the beginning. Many, many years back, the influences that led me along this path. I have to start with the Franco-German influences. Amit, of course, is very familiar. Most of my colleagues here are very familiar. My guardian angel was Dr. Yves Cottrell. You see, way back, I had moved to Bangalore and I was helping in running the ASSI conference in Bangalore. And Dr. Yves Cottrell was there. And I was assigned to take him around to Mysore and other places. He was very impressed with my abilities as a tour guide. So he said, I think you will make a good spine surgeon. Until that time, I wasn't sure where I was going to go. So that led me to this institution. It was the epicenter in those days for all that was happening, the new concepts that were coming. And I was interacting with all the spine surgeons. And my mentor there, Dr. Daniel Chopin, taught me how to appreciate spinal deformity, very different from what we were traditionally told to. And the three-dimensional correction, looking not just at the frontal deformity. So I trained there for a year, learned all the nuances of Cottrell-Debussy instrumentation, came back to India. And there was this child with the frontal deformity, but also her sagittal. Till that time, none of the spine surgeons, none of the deformity surgeons were looking at the sagittal X-ray. And she had a hyperkyphosis. So we had to address not just the frontal deformity, but also restore her kyphosis, correct her hyperkyphosis. And when we did this multi-segment instrumentation, unlike all the children that had been operated before and had to be in bed for 3 months or wear a cast for 6 months, this child could walk 12 days after surgery and go back to school. But what was at that time was the gold standard, and everyone, when I presented this particular case, there was a lot of pushback. This is not going to work. Harrington instrumentation is the way it should be done. And it was called the gold standard. But was it really a gold standard? Was it really a gold standard? An entire generation in the last decade of the last century and the first decade of this century, well-known surgeons in the US, in North America and Europe were making a career because there was an epidemic of sagittal imbalance following all the Harrington rod instrumentations that had been done 20, 30 years before. And as was discussed in the morning, PSOs became something that was discussed in all major conferences. An entire session or an entire day was spent in correcting lumbar kyphosis and restoring sagittal balance. So perhaps it was not the gold standard. When a child like this comes to us, all of us look at this deformity and do our assessments. And this is what we do. This is what I have done. Fix it, correct the deformity, get a good alignment of the frontal correction as well as the sagittal alignment. But this is iatrogenic ankylosis of the entire spine. Is it physiological to do this? Also, I would like to mention here that in the last 2-3 decades, there was a concerted effort, especially from North America, to address all issues of the spine only from the back. And even a well-known surgeon, like you can see here, said he had not done any anterior approach for 12 years. So a lot of our surgeons were great at putting pedicle screws. I mean, for us, spine surgery began and ended with putting pedicle screws in a very efficient manner. But that's not the complete spinal surgeon. I was fortunate, and Ram knows about it. In our early days in MIOT, where we were all together, we had a lot of tuberculosis. And like most other senior surgeons, this was a great teacher. And for us, anterior approach to the spine became second nature. It was very straightforward to open up the spine, to take the diaphragm down at all levels. And we became very good at it. This has stood by me in a very good way. And if there is one gentleman in my entire career whom I would call as the ultimate spine surgeon, it is Professor Jürgen Harms. And when I spent time with him, not only did I learn the concepts, but also I learned how to address all this in a very, very challenging manner. Very few surgeons I have come across who fall in that category, and only Professor Harms was able to help me understand spinal deformity and anterior deformity correction in a good way. Of course, I spent a lot of time with Dr. Zielke as well. So when a boy like this comes with a Lenke 4CN deformity, you see, he has a very severe thoracic deformity. He has a small upper thoracic deformity and a counter curve in the lumbar spine. Now, if we were to do it all from the back, which most of us would do, we would correct him from D2 to L4, maybe perform a thoracoplasty and PSOs. This would mean there would be a blood loss of at least over 1,500 ml, and we would get a good correction. But thanks to my training with Professor Harms, I started looking at these deformities in a different way. Way back, about 10, 20 years back, I was doing this in a routine manner. And we were able to get not only a good correction, address only the primary deformity, and have the lumbar spine correct spontaneously, and a good sagittal balance, and a blood loss of less than 400 ml, because the anterior approach is very friendly when it comes to blood loss, and get a good correction. Now, this is all about spinal deformity doing fusion surgery. For me, restoring motion has always been very close to my heart. And way back, I think in 2004, we performed the first lumbar disc replacement in this part of the world. And I was thrilled to address degeneration, not by fusion, but by restoring motion. So it has always been in my mind. For example, a Lenke 5, that is mainly a lumbar deformity. Imagine stripping all the lumbar spinal muscles in a 13-year-old child and fusing from L5. It didn't seem physiological. Also in Lenke 3 and Lenke 6, that is the double major curves. And of course, the Lenke 1s. So this new technique attracted my thinking. This is something I wanted to do. Non-fusion anterior scoliosis correct. But where it all started, it was called VBT, vertebral body tethering. But the word tethering has a very, very inert meaning. It means you just hold, you don't correct. But we have taken it And this is what I want to show where we have taken it forward. Of course, this child was the standard child for the classical BBT. She is perimenarchal, research 0, Sanders 4. She has a classical deformity. You can see here. And all the bend films that, of course, are always done. Here we have done a vertebral body tethering. As you can see, the deformity is not fully corrected. This is only tethered. And she growth modulates. So on the right, left, you have what we would have done in a standard way. On the right, this is what we have done. There is no fusion. 2 years later, you can see she has further corrected. And look at her on the right. Her spine is beautifully corrected, shoulders balanced, good sagittal balance, and no scar on the back. Now this child comes, 13-year-old girl. Her deformity has been noticed by her parents, has been progressive. They have tried other things. This is her deformity. You can see that she has Lenke 5CN, that is a severe lumbar curve, going right almost into the pelvis. Her pelvis is also a little tilted, as you can see in her clinical picture as well. Now, she also has an incidental spondylolisthesis at L5S1. What would be the options? These are our bend, stretch films. So the standard options would be a D8 to L5. But if you stopped at L5, her listhesis would be an issue. So you would then go to D8 to S1, or maybe even do a D8 to the sacrum and Ella. This is not what the girl's parents or she wanted. We did a non-fusion. This is an immediate follow-up, and at 2 years, she's holding well. And then you can see her immediate follow-up. This is at 2 years, and she is able to do a Bharatanatyam dance at 3 months follow-up. And she is able to do a Surya Namaskar, complete bending, which perhaps if I had done a posterior instrumentation, this would not have been possible. 16-year-old child attained Menaki at 12, a scoliotic right-sided thoracolumbar. Here you see her deformity. It's a 58 degrees, Rissa 4, Sanders 8. So she is grown, fully grown. This is a traction film. As you know, that I believe in doing a traction film for all my patients and planning on the basis of that. These are her clinical images. I would have shown you a few of the steps because this is an unfamiliar technique. I would have shown you a few steps, but I think due to time constraints, I will, those of you who are interested can come and directly speak to me. Post correction. A little bit of tilt, but she has accepted it and she is well. No blood loss. A severe lumbar deformity. That's the fluoro image after correction. That's her. And she is able to do that. She comes to these children are so comfortable because they are pain-free, unlike the children with the rods. This is 3 days after the surgery. She comes to my room and is able to do all this after a lumbar surgery. 13-year-old child with a deformity. She comes to us all the way from Australia. Now you see she has a double curve. Now, if you were to do it from the back, you would do from maybe L4 or L5 right up to D1. So her entire spine is fused. Her clinical images, she had tried bracing and all that. So she has undergone non-fusion correction of the lumbar as well as the thoracic spine. Post-op, maintaining well at 2 years. And she is at, now this is another thing. A lot of people ask me, what happens to the sagittal parameters? We have proven, and my junior here, my fellow here, Dr. Keyur has presented it in international conferences, the long-term restoration of the sagittal alignments. And this child is doing well, doing horse riding, doing gymnastics, and she is able to get back to full normal activities. Now I will set the cat amongst the pigeons. This lady comes to us from Pittsburgh. She is 40 years old. She has been diagnosed with a Lenke type 4 AIS, that's a triple curve, treated non-operatively in her childhood, but had extremely severe pain. She was not able to indulge in her favorite sport of running, marathon, decathlon. She had this deformity. And believe me, she went to all the well-known surgeons on the East Coast of America. All of them advised fusion, which would mean she would be fixed right up to the ilium, perhaps, or up to T1 and up to T1. Now in the morning, Ranjith focused on all the issues of adult deformity surgery and the complication rate. The cumulative reoperation rates are almost 25%. That is 1 in 4 cases would get a complication. And if you ended at S1, as perhaps in this lady, almost certainly you would have to go into the ilium. So you would have to revise her within a year or 2 of her surgery. So a multicentric study again has shown very significant complications, 39% complications, and 26% being reoperated for mechanical or neurological problems. So it's no wonder that she did not want fusion surgery. So her search brought her across the seas to India. We did an awake traction film which showed surprisingly good, reasonable flexibility. And we did a double curve correction, non-fusion. This was even reported in the Becker Spine Review that a US woman traveled to India because her insurance refused to pay for her non-fusion surgery. After surgery, she was able to return back, and within a couple of days, she was in a swimming pool, and within 3 months, she was back to her favorite sports. It is now almost 2 years since her correction, and she has not had any reoperations. Even if she breaks a tether, it doesn't matter. She will be well. Taking this further and further, I have now tried to push the limits with non-fusion surgery. So this child, born of a consanguineous marriage, was brought to us from Oman. This was before the pandemic. She had a severe deformity. Now, you can see she has multiple congenital anomalies affecting the upper thoracic and the thoracic spine with a deformity. Now, this deformity is actually very malignant. Left uncorrected because of the congenital malformations, it would quickly progress, cause cardiopulmonary issues in this child. She was only 7 years old. So I had very few options what to do. We could have done a growth rod, a magic rod at that time, but that would have meant every 6 months she would have to come to India. Post-pandemic, this would have been a disaster because she wouldn't have been able to come to India for 3 years, almost 2.5 years. So that would have been a disaster. I decided, after assessing her with all the scans and MRI and everything, the options were bracing, growth rods, or out of the box. Look at her clinical picture on the left. This is how she looked. Left uncorrected. We had an anatomical artist predict how the deformity would have progressed, and this wouldn't have been a pretty picture. So we decided to correct the main part of the deformity anteriorly. And this is where all the fun begins. Look at her on the left side. This is immediately after correction. They could not come to India, so they could send us pictures. 6 months, she is holding well. 18 months, she is still holding well. Fortunately, the pandemic is over, and now the tether is not holding any further. She is lordosing in the spine, and she is progressing. So we did a surgery just a few weeks back. I used the magic rod. So I'm going to kyphose the spine as well as correct on the concave side, do serial distractions, and she should be able to. We have one of the largest series in the world of AIS cases. As you can see, most of them are type 5, which we have operated. And we have had as good corrections as with fusion surgery, but the blood loss and all is minimal. The complications reported with this anterior surgery, for those who are not familiar with it, you can have thoracic duct injury, atelectasis, ureteric injury, incisional hernia. Of course, vascular injuries are rare. In our study till date, there have been no short-term or mid-term complications. We reported in the journal of, what is that journal? IJ, yeah. We reported there our early series, and we have just reported in 75 cases to the Asian Journal of Spine Surgery. So to conclude, the short-term results are extremely satisfactory. The cord may rupture, but recently my colleague from Germany, Bert Robisch, has come with this study that tether breakages do not require, especially if they happen in the long term. And touch wood, we haven't had any breakages till date. But it is all about meticulous technique and adhering to all the time to perfection. So in 1989, I started the CD revolution. That child did not have to wear a brace, or she could go to school in 12 days. Today, when I do the surgery in the morning, 4 hours later, the child is doing breathing exercises and walking in the recovery area. So we have come a long way. And I think this is the future. Thank you.
Thank you, Dr. SAJAN. And that's why I tell him that he's always 10 years ahead When I went for the first time in 90s, we were not doing deformity we were just doing deformity with Harrington. At that time, he was doing CD. Then we were fusing L4-5. I went to him, I saw the disc replacement. Then in 2006 or 7, when we were just putting percutaneous screws, he was doing with robotics. And now when we are fusing the spine, he's already 10 years ahead and doing anterior teeters. Thank you, Dr.
Thank you, Dr. Sajan, sir. May I request our president, Dr. G.D. Tharadara, sir, to felicitate Dr. Sajan, sir, please. So, please. Thank you, Amit bhai. So we'll start the next session now. Next session is by invited faculties. Pratik, you are taking over the session. Next session. Anil.
Hello. After this session of tethering, we are now going further towards the complication in invited guest lectures. And for that, I would like to welcome on stage Dr. Vijay Sata, Dr. Hitesh Modi, Dr. Jawahar Jethwa sir. Over to you, Hitesh sir. You can call upon for the next presentations.
So I would like to invite Dr. Ram CHADDHA sir to give his talk on high-grade spondylolisthesis. Ram sir.
Morning, everybody. May I have the first slides, please? After this phenomenal presentation by Dr. HEGDE, I'm sure that you people need a breather. So I'm presenting something quick in, quick out, something which also SAJAN and his entire team has been doing over the years. And they probably have the largest collection and experience about the same. I speak about high-grade spondylolisthesis. I'm going to talk about how to reduce. One involves preoperative planning, positioning, intraoperative maneuvers, role of instrumentation. Let's look at what all would you look for. This is not a high-grade listhesis, but it's more common that you should look for it in a high-grade spondylolisthesis is a root anomaly. For those who have never seen root anomalies, and a lot of radiologists have not, please look at an axial cut. And if you see that cut there, there is an additional splaying of the root. Can you see that? You see a root on the right side, but the left side, there's no root. It's all conjoined. It's a continuous sort of a duck's paw or a duck's a footprint that you see there. That is what should be at the back of your mind, especially in high-grade spondylolisthesis, because these are situations where if you were to put in a T-lift going in from that side where there's a conjoint or a root anomaly would be a very big challenge, and you may need to change your plan. Besides this, what else do we need to do? Well, we need to go ahead. Not moving, brother. We need to check the AP and the lateral views on a plain film if you've not done a CT, and check whether we are dealing with any hypoplastic pedicles. We have to always be sure of the pedicle size because it's not uncommon to have pedicular anomalies. And just like in scoliosis A, B, C, D, you have to be prepared for looking at smaller, thinner pedicles. Besides that, do your dynamic films. It'll give you an idea of the correctability you may achieve on table. Always correlate your symptoms and the side that you need to go in. Yes, one side usually predominates, and by choice, we prefer putting in our spacer from that side. I always do it open. I am not as skilled as many of you are in doing these things percutaneously. I used to take a long incision. My incisions have gone shorter, but still it's an open procedure. I place them standard on an operating table. High-grade spondies, we may have to at times flex the knee and extend the hip and play with the sagittal situation on table to get the best balance. Aim of the surgery is not to correct the translation, but to correct the kyphosis at the lumbosacral junction. Do that during positioning. Check your AP and lateral. AP viewing is important. And please see that your C-arm can give you a good AP view. Otherwise, you struggle during the procedure. Check your implants. Check that you have a rod reducer. Check that you have a working rod you can contour with. Have your preoperative plan in the mind. Are you doing short segment? Are you also going to look at 4 or 3 or 2 and plan it? Do what you do normally. If you're used to getting them up to L2 or L3 and then pulling them back, do it. If you're capable in your hands to do it with L4, do it. And if you're capable of doing it at L5, you're so brilliant, go ahead and do it at L5 S1 alone. Check your reduction screws if you use them. If you're one of those who uses reduction maneuvers and reduction devices, have at least 2 sets to do them simultaneously. Please insist on that with your instruments provider, because doing it with one at times is a huge struggle. Plan your entry points when you're going in. Once you've done it, do a complete exposure. In high-grade spondylolisthesis, do your complete lateral exposures. You have to actually decompress both your roots up and down on either side, identify them, and then begin your procedure. And I begin with my interbody work. Yes, I stand here and say that I begin with loosening my interbody work first before I put in my screws. I'm subject to any form of discussion, but I still do it that way. I loosen up the whole thing, identify all my roots all the way down, and then begin my work. Then I go and identify my pedicle. Yes, the fascial bleeder, coagulate it, use bipolar, be very, very specific that you don't injure the nerve root is routine, but you have to do it more specifically in high grade. Excise all that fibrous tissue. There's a lot of bone looking fibrous tissue, but that's not bone. You have to identify your point of entry very, very well, because a lot of fibrous tissue gets sort of pseudo calcified and you may actually get a wrong point of entry and struggle because you have only one shot at that L5 pedicle. Be very, very clear that you've identified it before you go in. It is hypoplastic or aplastic. That's to show you that you may have root anomalies, more than one root, or at times a large conjoint root. So be prepared for that. You may need to switch your side even on table as far as placement of your spacer is concerned. Having done that, I do a good decompression. I open up. I really sacrifice my facet. I am not there to save my point of entry. In fact, I need more bone and I need a good point of entry to get into my disc space as lateral as I can so that I can put my spacer all the way across. Please understand, unlike those which get completely reduced, where they get partially reduced, you actually have to go as lateral so that you can use that small space also to get your spacer ideally placed. So keep that at the back of your mind. Loosen the space, use bipolar, cover the dura with wet gauze. This is my major take home for you. Once you've done all your decompression, cover that with copious wet gauze and then start your implant procedure. We've all gone through it where instruments slip out of our hands and injure and cause iatrogenic issues. So put an amount of good wet wet material like a gauze piece, which you keep wetting all the time when you're doing the hard work, not the soft work. I used to use a lot of monoaxials when monoaxials were genuinely superior to these multi-axials or polyaxials. but now they are equally good and I use either or. Monoaxials was my go-to when I used to do it with my Steffi or at time because Steffi just had that. And later I moved into the CD or the other systems where monoaxial gave me a better hold. But today I believe that all of them work as well. Sacrum has always to be bicortical or tricortical, if you might want to call it, going all the way up into that area where you get the maximum chunk of bone. I may use a reduction screw. I don't do it every time because I use my rod reducers very well, and I use all sorts of rod reducers, combining and doing it slowly, progressively. The reduction maneuver goes on for 45 minutes to an hour, and it's done every 10 to 15 minutes. Do I use monitoring? Yes, I do use monitoring nowadays for that. Optimal length, diameter, the maximum size, the maximum diameter, the best direction that you can get. I am very, very particular. I do use imaging because I don't want to go wrong. There are people who are more talented and more brilliant and don't use imaging. I am not as brave as yet. I use intraoperative neuromonitoring. I do a lot of work with working rods. I keep replacing rods, recontouring them, playing with rods, using an increased amount of lordosis in my rod to get more and more correction, changing them time and again. I do bilateral correction. That's why I said insist for 2 sets of rod reducers to come on either side. I hardly ever do distraction, and my distraction is interbody distraction. I do not do interscrew distraction. Again, I stand up and say, I do not do interscrew distraction. My distraction is with my pucca that goes in and chucks it all the way around. Lateral point of entry, complete discectomy, protect the roots in the cauda, sacrifice and completely remove that inferior articular process. I use that funnel, which I have always used, which I created and is now easily available today to push in my graft right at the front and pack a lot of graft. Do I use graft? Yes, a lot of it. Do I believe in using more than I think it should be there? Yes, I usually pack more than I can, all in front of the spacer. I don't put graft behind the spacer and minimal graft within the spacer. I pack anterior, protect the roots, as I've said. As I said, I look at all the 4 roots. Symptoms may be one side, but I've cleared all the 4 roots every time. I do a good amount of bipolar coagulation around it. I use bone wax and gel foam where required. Post-operatively, hip extension, knee flexion for the first couple of days may be necessary. I'm not a proponent or a user of steroids. For those who do it, go ahead, enjoy yourselves. I do log rolling. I do believe in DVT prophylaxis. Parenteral antibiotics goes on for drain removal or catheter. It may be 48 to 72 hours. I do a check X-ray early. How much to reduce? As much as desired and safely possible. Achieve the 4: decompression, stabilization, fusion, and restore the sagittal balance. What's mentioned here is that reduction has several advantages. Hence, trying to get as much as possible is the best. Correction of the lumbosacral kyphosis is important, not the translation. Always do proper counseling, do intraoperative monitoring, identify all the roots, gradual reduction over 45 minutes to an hour, correct the kyphosis. Sacral flexion needs to be corrected. You need to do at times a dome excision. I do this gradual reduction maneuvers. This is how it works, that there is a stretching on the nerve roots, which has to be gradually corrected over a period of time. As you correct it, this is the sort of maneuver where they'll auto decompress if you've done a dome correction or an excision and shortened the posterior column rather than lengthened in. Please understand it's the L5 nerve root which gets actually tethered in more than 70% of the chances in the second half of the reduction. So be very, very, very slow about it and do a partial reduction and hold on rather than satisfy your ego and get more. Contralaterally also clear off, which I've already said. And there are times, remember this one slide, if your S1 screws have gone laterally, you may be injuring the L5 nerve root. So be aware of this, and this is just for the sake of completion. Finally, remember, occasionally you may use a Gaines procedure, occasionally you may use a delta construct, but most of the times you have to do what I have done, which is 80 to 90% of the times. And finally, if there's no go, poor patient, bone quality is poor, you may get out with an uninstrumented lateral, posterolateral fusion and say your prayers. Thank you all for a very patient answer.
Thank you, Dr. Ram, sir. And we know your love for pre-op planning. I think perhaps your initial engagement with GOA was surgeries are like marriage. I don't know, you still remember that?
I remember it for more reasons than one.
So maybe take 1 or 2 quick questions.
I would like to ask Ram sir about your recommendation regarding the pelvic fixation in high-grade spondy.
I have actually not found the necessity in using that as yet. Probably I have not wanted to get such a dramatic correction and I've accepted for the less. But revisions where they have failed or where they have not worked or there is a pseudarthrosis, yes, I have had to do a few extensions. But as an index choice in most of these lytic high-grade spondies, no, I haven't used it.
Thank you, sir. Thank you.
Now going for kyphosis principle and pulse of management by a very senior and experienced Dr. S.K. Srivastava, sir.
A very good morning to all of you. I thank SSG, Dr. Neeraj and his entire organizing team for giving me this opportunity to interact with you. This is a very difficult issue of correcting the severe kyphosis. I'll be addressing that part only, though the reference will be given to other etiologies also. It is important to know about the pathogenesis and altered biomechanics of deformed spinal column. Whenever you wish to correct a symptomatic significant kyphosis, you must pay attention to altered sagittal vertical axis. This parameter is extremely important, and many people have touched this point. Now, whenever you do this, pay respect to the SBA. That is going to give you long-lasting result. Now, this etiology is very common in our country, and many of us, face this problem, how to manage this. In wet lesion, even if you have a significant deformity, this is the golden opportunity to correct the deformity. And I think this, stage should never be missed, and you should try to correct it fully. Anks are the different ball and issue. And this game is really difficult because these patients are really significantly disabled. And if you wish to correct it, your planning is extremely important so that in this patient you gain the gaze, and they want to have a horizontal gaze which is not parallel to the ground, but it is parallel to the vertical axis of the sky. Now, these patients, if they have peripheral joint also ankylosed, then their compensatory movement is also compromised, and we should take note of this. Congenital kyphosis, it progresses very fast if the posterior structures are growing very fast, and you have to take note of it and try to intervene early. Sermon's disease, they have round kyphosis. So here you cannot have a planning of correcting the angular kyphosis. Here you have to set it at the different level, at multiple levels. Neuromuscular kyphosis are usually associated with scoliosis, and many a time the aim of surgery is to provide sitting balance. So you need not do the very heroic job here. These patients are already compromised. In degenerative kyphosis, they are basically elderly patient, and you must respect the presence of osteoporosis and sarcopenia, because if you don't treat this, these implants are going to come out. Try to see the compensatory mechanism in this patient when you do the clinical examination, and try to achieve the global balance in these patients. It is extremely important. Sometimes your kyphosis extends to the cervical area and lower down also. So pay respect to that. The SBA should be there within 4 centimeters, whether it is cervical to dorsal or it is from dorsal to lumbar and sacral region. Try to pay attention to all these parameters. This is extremely important, and that should be religiously included in your preoperative planning. Now, if you see, all these are kyphotic deformity, but all are different. Etiology is different, and the apex is also different. You see, I have tried to draw all the apexes. So here, your planning is not going to remain the same. How much you are going to exercise, how you are going to align the column. So planning is extremely important. This is the most important slide of my talk. You have to have a very good clinical assessment. How is his nutritional condition? Is there any neurocutaneous marker? How is his chest? Is there any chest deformity? How is the plumb line? Whether there is any compensatory effect. And sometimes there are very subtle neurological deficit and you might miss it. So be aware about that. Apart from long X-ray, MRI, the CT is required in many of the situations. In elderly patient, ask for BMD, vitamin D, calcium, and PTH. Treat them first medically and then do jump to surgery. In chest deformity, always ask for PFT, ABG. ABG extremely important. Preoperative, you should know how much is the ABG, and then postoperative, you can compare it. This is extremely important. Always stick to the preoperative protocol, and you should have your own protocol as a surgeon. Preoperative preparation is extremely important. Build up their nutrition, build up their chest capacity, and have a very open discussion with the patient and the relatives. This is extremely important. Careful induction and proper positioning is very important. As an index surgeon, you should be present at the site. This is extremely important. Neuro monitor and power instrument are essential, and if it is better, then if you have it. Basic principle: never allow the MAP to go below 90 millimeter of mercury. Your working hand should be always supported so that there is no flying of the instrument. Least neural handling is permissible, and you should have a temporary fixation once you are about to disengage the column. This is extremely important and vital. Avoid opening the wedge. Try to do the effective column shortening procedure, and during shortening, be aware that you are not crowding the neural tissue, because that will lead to deficit. So for that, you can have a controlled anterior restriction. Sound reconstruction is extremely important, and I will show you the failure in some time. Surgical planning and intervention is also a very, very important basic rule for this surgery. If there is a mild to moderate kyphosis, you can get away with the eggshell procedure, PSO or SPO. But for VCR, you have to have your plan in place. You can have in TB wet lesion or healed lesion. Wet lesions get corrected very easily, but for healed lesion, severe deformity, you have to do the VCR. When you have angular kyphosis, it is basically the localized angular osteotomy. When you have a round kyphosis, you can do multiple osteotomy at posterior side, and you can compress it. Sometime you have to put the case or graft anterior to have a good compression. When if it is correctable, usually it comes easily. When in ANCS, again, you have to do the angular osteotomy and try to have an alignment which is acceptable in that situation. For severe kyphosis, you have to do the meticulous planning, preparation, and execution is important, and you have to do this. Circumferential excision of the apex is important. Holding of this disengaged column is important, and anterior reconstruction is extremely important. This young boy I operated, and he was doing fine. Knowingly, I had put the wire in the proximal area because usually they topple off later on. But see, when he had a fall and everything came out, we have to change it and convert into hybrid fixation, where I used a hard seal rectangle, cut the transverse bar, and then put in the already existing screw, and he came out nicely without any problem. The basics of meticulous planning in VCR, you must address the apex. Now see, here usually we'll end up doing the just internal gibectomy, and the overall correction looks good, but there is a problem. Basically, you have tried to correct proximally and distally. The apex remains same. If you analyze it, it appears that you have just done the internal gibectomy, and vertebra at the apex remains tilted, and there will be problem. In the proximal and distal vertebrae, the posterior part, it kinks over the spinal cord, and then there is also problem in reconstruction. Your surface is not smooth, and the loading will not be proper, and the contact area is poor, and it has led to all these problems. So apart from the loading, there are other issues also. Now, suppose you end up doing this, what is the way out? You can just take out those edges, and apart from putting the anterior strut, also add these adequate onlay graft, and you will find that he has reconsolidated very nicely. What are the different steps in VCR? You disengage the column. Don't try to compress at this stage, otherwise you will have a kyphosing effect. So first try to have a sagittal rotation, control with the distraction, and then do posterior compression. So that's how you try to correct it. It gets aligned, and then you try to have these steps in sequence and try to get a good correction. So proximally, there were screws, which are the reduction screw. Try to disengage the column gradually. Do a generous laminectomy posteriorly. and then have a control correction. And then you try to have this leverage of extension of the table to help you in the correction. Contour rod can be changed to the final rod, and then you try to gradually correct and try to reconstruct it entirely nicely. Now, wake-up test can be done after the final correction. Anterior grafting or strut grafting is important. Here we have used the cage and we got a good correction. It is after CT, you can say, and there was a good correction clinically. Another child, he was bedridden, severe deformity. The same thing we applied and we got a good correction. You can see the CT also, there is anterior good correction, and this child started walking nicely. So I'll conclude, severe rigid kyphotic deformity correction is a demanding procedure. It requires proper planning, meticulous surgical execution, and reversal of the proper apical correction. Apical correction is extremely important. Sound biomechanical alignment and anterior reconstruction usually gives a long-lasting, fruitful result. I thank you very much for your kind attention.
Thank you, Srivastava sir. I think due to the shortage of time, we would not like to take any questions. And we have slight change. Thank you, sir. We would have slight change in our presentation. I would like to invite Dr. Sandeep Sonone for his talk on principles, rationales, and challenges in cervical deformity correction. Dr. Sandeep.
So thank you very much. And moving on to the more complex problem of what sir showed, the cervical deformity. So cervical deformities are basically not rare for spine surgeons, and each and every cervical deformity presents a diagnostic dilemma in itself. They come with varied clinical presentation, with deficit, with instability, with malalignment of the sagittal and coronal axis. Management is challenging in each and every case, and it has to be individualized, and the rate of complication is quite high. So if we look at cervical deformities overall, we can basically divide them into three parts. The supraaxial spine, which deals from the occipit to cervical, that is the O up to C2. And we all know that this is a different topic by itself. We can have a separate session, probably a separate conference on this. Subaxial is when we have deformities ranging from C2 to down to C7, and they can again present in sagittal and coronal planes. However, coronal, in my experience, is very limited. Most of them present with cervical in sagittal deformities. And then the most common of them is the cervical dorsal deformities, where the cervical spine is sucked into the thoracic spine. And then these cases present a dilemma. And we will have a look at why this particular area is more common in our day-to-day practice. So the decision making depends on a lot of factors, as suggested by SK sir. Etiology, whether it's a healed lesion or a wet lesion, that makes a huge difference. Whether it's an infective pathology or whether it's a progressive deformity. Clinical presentation, whether we need to attack the deformity immediately or we can wait and plan if it's a progressive deformity with no deficit. What are the biomechanical parameters, as has been shown by sir, and again I will brush upon that. Whether it's a localized deformity pertaining only to the cervical spine, or whether it has got an implication on the overall biomechanics of the spine, and other factors like patient and surgeon dependent factors, the age of the patient, the morbidity of the patient, and obviously how trained are you as a surgeon in dealing with these complex deformities. More often than not, the clinical presentation will tell you the diagnosis. So if it's a mechanical component, which is pain, instability, and progressive deformity, it is usually infective or healed deformities or tumorous conditions. Whereas in cases where there are functional disturbances like gait disturbances and horizontal gaze affection, it's a more generalized deformity, which can be because of angst-pond. So dealing with the area, I'm not going to go too much into the depth of the supraaxial deformities. As I said, it's a different topic in itself, but certain basic principles apply. Here, there is a dislocation, there's an increase in C1, C2 angulation, kyphosis, and failure to address these particular issues can result in disastrous complications if you don't understand the nature of the deformity quite well. So here we have a dislocation, we have a translation, and we have kyphosis. And in order of severity, the correction moves from correction of kyphosis,
correction of translation, and the last is correction of dislocation. So you can have your own ways of doing it, whether by just doing a posterior surgery or doing an anterior surgery, but the basics remain the same, that you need to realign the column, the C1, C2 complex. More importantly, correct the kyphosis, because kyphosis is not good for the cervical cord. There are multiple studies which show that there are myelomalicic changes because of persistent kyphosis, irrespective of the neurology of the patient. So prevent a sick cord, align the cervicomedullary angle, and align the clivus canal angle. So these are the three basic steps. Now, when we go to the main part, that is the subaxial and the cervical dorsal deformities, the crux of the problem is that we know that the cervical spine is a mobile lordotic segment which blends into a fixed kyphotic thoracic spine. And this is the problem. This is the main area of concern. That's the zone of transition, and it has got a major impact on management. So we have the vertebral bodies and disc anteriorly, which are held posteriorly like a reins by the posterior elements, facets, and ligaments. And instability in any of these, whether the anterior column destruction or posterior tension band discontinuity, can result in progression of these deformities. So here we have to take a pause and understand what is the problem. Is it the failure of the anterior column, which requires a good reconstruction, or there's a failure of the posterior column, which requires a good tension band restoration? A few radiological parameters to give you an idea: the C2 to C7 angle, which gives you alignment, a good idea of the deformity, the nature of the deformity. The C2 to C7 plumb line, which gives you an alignment of the overall sagittal axis. The T1 slope, which gives you the nature of the progression of the deformity. So if you have a deformity and there's a huge T1 slope, more likely that these deformities are going to progress. The thoracic inlet angle obviously depends on has a huge impact on the surgical management. So if it's a narrow thoracic inlet angle, probably it's difficult to go in anteriorly. And the other factors like the overall alignment of the spine in Angst-Pond, the chin vertical angle, which has got a huge impact on the horizontal gaze, as shown by Sir. So what are the challenges in management of these cases? So here you can see there's a significant deformity over here, a kyphotic deformity. In deformity, there are three principles of management. One is a good decompression, reconstruction, and a good fixation and fusion. So how do you achieve all this? How do you reach to the apex of the kyphosis to get a good deformity correction? What are the reconstruction options? Whether you want to use a graft or you want to use a tricortic, you want to use a cage. And finally, what are the fixation points? In the cervical spine, we have limited options. We have the lamina, we have the lateral mass, and the pedicles. Depending on the strength, the pedicle has got the highest hold of the anchors. And obviously, if you are using the lateral mass, which is the commonest use anchor, then you're losing out on mobile segments. So preoperative traction helps. If it's a supple deformity, you can just give preoperative traction, open up the anterior column, and go in and do a straightforward anterior reconstruction and posterior fixation. The problem comes when there's a healed deformity. In that case, then you have to plan it depending on the safety. You might have to go in posteriorly, break the posterior fusion mass, put in your anchors, come in anteriorly, again going posteriorly. So you might have to stage these deformities. Now, cervical dorsal deformities are extremely challenging deformities. These are deformities which can give you sleepless nights, multiple issues, whether you need to go in anteriorly, posteriorly, combined approach, single approach, or stage approach, especially in pediatric group patients. What are the reconstruction options? Because here you have to understand that it's the lordotic cervical spine blending into the kyphotic thoracic spine. So you have limited reconstruction options. What are the implants? What size screws do you use? You use 3.5 mm screws, use 4 mm screws, use 4.5 mm screws. So again, these issues are there. How do you use a rod? Do you use a taper rod? Do you use a standard rod? Do you use sublaminar wires to prevent toppling? How do you control the column translation once you correct these deformities? This is a step I'm always paranoid about. It's very difficult in cases where you do a tri-column osteotomy, detach the column, and you just cannot control the proximal column. You have to have multiple options. You can lift up the head of the patient. You can have an assistant holding the head. You can use reduction screws. So these are a different set of challenges. And then apart from that, there are other challenges like, blood loss, post-operative immobilization, and monitoring. So surgery at the cervical dorsal zone presents challenges in itself. Basically, you have anterior posterior approach where you can do an anterior reconstruction, instrumentation, or posterior instrumentation. Anterior approach, two important approaches: the low cervical strap muscle release or the manubrium split. And these are the factors which will have a decision making. So the zone, the area, the level of the sternal notch, the arc of the aorta, the thoracic inlet will decide the approach. So here you can see that the sternal notch is at the lower instrumented body. So I can go in with a low strap muscle cervical approach and do a good reconstruction. Whereas if the lower instrumented body is deep into the thoracic cavity, then probably you need to split the manubrium. It helps in instrumentation. If it's a limited thoracic inlet, as I said, that the thoracic inlet angle, you cannot approach it anteriorly. You have to do all posterior surgery. Posterior approach, the advantage is that you can do an anterior reconstruction and a posterior fixation at the same time, however is the severity of the deformity. But this will work only below C7. In Angst-Pond, C7 osteotomy is an option, but all these posterior approaches will work only below C7 level. So this is one of the case where we have gone in, done a good all posterior deformity correction, had a bone-on-bone anteriorly, and use all sorts of ped anchors to give a good correction. And obviously, surgery is the beginning of treatment in these cases. You have to immobilize these patients properly. As I said, all posterior surgery at Angst-Pond, in Angst-Pond, C7 osteotomy, the advantage is that the vertebral artery is absent. So C8 root injury have less consequences. And there are multiple steps. I will not go into the depth of this, but basically you can have anchors proximally distally, go through the C7 zone, do a eggshelling procedure, and gradually close with the help of reduction screws. In cervical dorsal deformities, this is compared to a long bone, right? If you have a long bone fracture, you don't put in a short plate, you use a long lever arm. So what has been advocated is that if more severe the cervical dorsal deformity and you do a good anterior reconstruction, which is mandatory, you have to go in long. You can decide your anchors, whether it is pedicle screws, lateral mass, and obviously these are taper rods, which are the only options that we had right now with 3.5 mm screws. So to conclude, cervical dorsal deformities and cervical deformities are difficult to manage. We need to consider the biomechanical parameters. The approaches can be challenging. The reconstructions, you have limited options. Anchors, you have limited options. And the only way that you can do this is plan, plan, and plan. Thank you very much.
Thank you, Dr. Sandeep. Now inviting Dr. APPAJI for guiding us about neglected scoliosis fixation and navigation. As we have noticed, Dr. CHADDHA as well as Dr. SRIVASTAVA has focused a lot on pre-op planning. The same has been story for Dr. Sandeep. And now we are ready for the toys of the boys for successive 2 lectures. Dr. APPAJI, please.
Yeah. Morning, everyone. Thanks, Neeraj, and the other organizers, Ajay sir, Bharat sir. Nice meeting Amit and Senior Prabhakar sir and Taradra sir. Thanks for having me here. And my topic is navigation through a neglected scoliosis. So we'll define what is a neglected scoliosis. If there is a deformity which is beyond 90 degrees and correcting less than 25%, and if you have told surgery to the patient and the patient is not had surgery for 6 months, rapidly progressing curve is all neglected scoliosis. So the flexibility here, we are dealing with something which is more the dynamics of it is more, the flexibility is less, and you're dealing with somebody who is not believing in you because you've already told surgery and the patient has neglected your indication and your advice and has gone on to become a severe rigid scoliosis. So the reasons for getting a neglected scoliosis is ignorance. It's not ignorance of the patient, the parent, it's the ignorance of the primary physician who saw the patient and told, you may have to wait longer. First, it may not progress. Second, and not guiding them properly to the surgeon who will actually treat them. The second most common thing is fear of surgery. So most of the patients you have told surgery, but they don't want to get a surgery done. They look for other modes of believe in other modes of treatment, Ramdev Baba's yoga. And I mean, I've had patients who have been buried in sand for days. I've seen a kid who has been buried in the sand for 48 hours to correct scoliosis. Dig a pit, put the kid in till the chest, buried in sand. I've seen a patient like that. So it's the belief. So you get patients like that. What is the etiology of neglect? Anything, any neglected scoliosis, anything can become neglected. So if the patient has not agreed for surgery with any etiology, it becomes a neglected scoliosis. So one of the few cases which I could follow up. So within the child came at the age of 2, that was 3, and that was 4 years old. From a degree of 20 degrees, child became 75 degrees within 2 years. So infantile scoliosis are the worst. So you have to treat them. Second is this neurofibromas, which can come with those angular scoliosis. So this boy came with like 120-degree scoliosis in a very short segment. So these are another types. And this is mainly because the patients notice, but they don't seek, and they are rapidly progressive also, and they don't seek the treatment immediately. The issues we are facing for treating these is how to navigate is these are fixed deformities. Unlike the regular AIS where there is flexibility, most of the stress will show you that you can correct 50 to 60% even through your stress films. Most of them will have pulmonary function compromise because their deformity is fixed. They may be associated with pain and neurodeficit, and you have a doubting parent and a doubting patient. So he's not actually still believing that surgery can correct the deformity. So how will you work up? So treatment starts from the OPD. The patient is there. First thing starts with counseling the patient and the parent that there is a severe deformity. You have neglected it. You are responsible for this severe deformity. It's not the surgeon or the God. You are responsible for it. And then you do your radiology. Radiology, as described by SRS, should include from occiput to the pelvis so that you make sure there is, and it should be a PA and a lateral X-ray. Both should cover occiput to pelvis. The bend films to ascertain that you are dealing with a rigid neglected scoliosis. The additional test, as I said yesterday, also is MRI screening. We do it as a routine now for almost all scoliosis patients. Pulmonary function test and 2D echo in these patients. Yesterday we had a discussion. If some of these severe rigid deformities in the chest can have a cor pulmonale, they can have a right heart failure already having a PAH. So you have to grade them and give the prognosis upfront before even you decide on surgery. So a picture like this in the SRS, you will get all this. So pre-op planning starts with counseling, pulmonary function improvement. You can look at traction. Yesterday we had a good discussion on what traction we can use. I think Guru was telling us halogravity or a halo pelvic traction is very good. A 3D printing model, if you are planning for instrumentation, to plan your anchor points, to plan your osteotomies, if you are planning for osteotomy, and look at the nutritional status. So preoperative traction, I've used the halogravity standing and the halogravity lying down. So both we have used. Halogravity lying down was for 3 to 4 weeks, but halogravity standing mobile patient we use for 6 to 7 weeks in most of the patients. We have had 1:1 3D printing. These are like real model, real size models. You don't get those small printed models. Get the real printed model so that you can see the pedicle, you can plan your anchor points, you can plan your osteotomies even before you go into do these surgeries. Involve the team. Form a team upfront. Involve your team. Involve your physiotherapist. Ask him to work on the patient's lung. Talk to the anesthetist. Tell them that you are going to have such a patient. Be prepared for whatever the surgery is going to be. Involve the ICU consultant because he is going to be involved in the post-operative care. Involve the nutritionist, and not the least is the blood bank person, because suddenly you may require 5 to 6 units intra-op and immediate post-op period. So you be prepared with the blood bank also. Intraoperative, as we all discussed, what all modalities is available, you have to be prepared in severe rigid scoliosis. Osteotomy sets, you have to be prepared with all allografts, iron, everything. And what we follow in our setup is we use an intraoperative traction too. We have published paper. I think KU has spoken about it, not KU or Hardik. One of them have spoken about it. We use an intraoperative traction, which has actually helped us reduce osteotomies. So a curve nearly 100, you stretch them out over time, and intraoperative traction actually corrects more than 30–40%. And then we were able to do less and less bony work and achieve a better correction. We almost use the intraoperative traction for any curve more than 75 degrees. So this is how we use it. We have a skull tongue traction, more than like 8 to 10 kilos on the head. And both the legs, we have a bony traction, which comes to around 4 to 5 kilos on each side. Intraoperative neuromonitoring, involve your neurophysician. Better to have a neurophysiologist than a technician in these rigid deformities, because the technicians will tell you, sir, it's gone, but they won't know why it is gone, how it is gone, and what are the steps you need to take. So Before the skin incision, make sure on positioning and after traction, you have the neuromonitoring already in place. Do not do the skin incision and then the fellow says, sir, I'm not still getting, that is a wrong thing. So make sure before the skin incision, you have all the traces, both MEP and SCCP. Neuromonitoring, then be prepared for the anchors. So pedicle screw is the mainstay. So wherever you can, plan to put the pedicle screw, freehand, navigation, O-arm, robot, whichever you have it, whichever you are trained with. As much as possible, get good anchors in the apex. And if you get a good screw, try to prevent a screw pull out by using additional supports at the apex. We have used sublaminar bands, which are there, PFT bands, which we tie it to the rod, so that gives you the pull strength to the rod. Releases, anterior releases, we used to do very, very routinely long time ago. Last 7-8 years, I think 10 years, we've stopped doing anterior releases. We do mostly posterior releases. Facetectomies, osteotomies is being spoken about regularly. There is a new concept of concave side rib head excision for severe rigid deformities for you to. And you do the pre-planned execution. Do not go in thinking I may change my plan. Most of the time, that is where you land up in soup. So you plan properly, go in and do the pre-planned execution. So correction maneuvers use almost all techniques. Yesterday we talked about rod derotation, cantilever. Most of the time in a severe rigid deformity, cantilever and translation is the mainstay. Then comes your rod derotation, check IONM in all steps. If there is an adverse event in IONM, stop the surgery, reverse your steps, go back. Try to attempt one more correction. If the IONM drops again, stop at where you have got it. Do not proceed with the surgery. If you have a neurophysiologist rather than a tech helping you, he is most often correct that you are wrong. You have caused some problem. So some of the examples where we did an anterior release and posterior correction. This boy underwent 3-level Ponti's osteotomy. And this patient, actually, we had put on a traction for almost 6 weeks, halo gravity. He never corrected. Even the traction film, you can see standing and traction film, there was no correction on this. I mean, a girl, not a boy. And then we did 1-level asymmetrical PSO, and then 2-level Ponti's to achieve this correction. Yeah. And one of the recent cases which I have called Dr. HEGDE to help me because of this grotesque 120. This boy also was on traction for 4 weeks. And then we did a cervicodorsal correction with a minimal posterior releases. Last 2 slides, yeah. So the last point in a severe rigid deformity is thoracoplasty also, because most of the time you would have achieved some balance, but the thorax will remain as a razor chest deformity. So there are 2 ways of doing rib excisions. One is the standard way where you go to the transverse process, remove the posterior part, or do only the rib excision at the apex. That is what we follow mostly, apical rib excision. So partial resection, usually we do around 4 to 5. Maximum you can do is 6. Start at around 4 because the scapula covers 4, 3, and 2. They are much deeper. And 11 and 12, you don't have to because they have floating ribs. So we do around 5 to 6. You can see the thoracoplasty which has helped in this boy. Even though you have corrected him nicely, but the rib hump was still persistent. So we removed 4 of those ribs. So post-op care, ICU care if required. Be prepared for post-op ventilation. If the surgery went on longer and you had more blood loss, replace blood as much as possible. Mobilize as early as possible. We have not used brace, but Ranjith will not agree. He uses brace for every post-operative patient. Conclusion, as everybody says, you have a proper training for handling such patients. Build a team, involve all the members pre-operatively, plan meticulously before going to the theater, and execute your plan. Expect the unexpected, be prepared for complication in these patients. Thank you.
Thank you, Dr. Appaji, to teach us what not to neglect in neglected scoliosis. Thanks for your inputs. Now I would like to call upon Dr. Bharat Dave. I think he does not need any introduction. However, I would like to say that we all proudly say that I am proud to be an Indian. Simultaneously, I also would like to say I am proud to be a Stavian. So what I am is because of him. So I would like to invite him over to you, Bharat sir.
Thank you. Thank you. I have 8 minutes to share about the gadgets in the spinal deformity. I won't be standing here if I won't have my colleagues and my team with me. It's not moving, is it? Okay. I have a few disclosures. I'm the advisory board, and we have the Medtronic fellowship running as well. This is something 1987. I was in a second year resident, and when we had the SECon, and that time the Dr. Dinubhai Patel had this kubja, which was on the tile, you know, the bathroom ni tile super, you know, it was all printed in that. In 2019, we had the same, and that was the theme. And now we have the eternal spine surgeon, Krishna, in our consulting room as well, in the waiting area. The gadgets, we all know that we keep on changing the mobile. We keep on upgrading ourselves. Same thing we have learned and done for our vehicles as well. And the most important thing we all really want to have is the fast track. And I think something we really need to do is unwind ourselves, whatever we have learned. I think a lot of things has been discussed, and probably, you know, the best lesson was from Dr. SAJAN HEGDE, that, you know, we really need to unwind and really need to relearn whatever is happening in the current spine treatment or spine scenario. So let me, I think the one that I had given that change in the slide, the last slide, it did not change. I had the summary slide first. You do have the summary slide first? Okay. I wanted to have the summary slide first, because then I will overrun and then I won't be able to conclude. So let's have the last slide. Last slide. No, I think it will be, I wanted to have the, because that's what I changed and you did not change. No, but then I wanted to have the last slide. Forget it now. Yeah. Is there an end? Because I'm not used to the Mac.
PowerPoint just put the word end. It will end and put the last slide. End. There should be an end somewhere.
Okay, let me just conclude this. How do I put this slide? Last slide. Okay. So IOTSS is integrated operation theater spine suit. That's what the word that we use for the gadgets that we have. And that will enhance the patient safety and improve the outcome. And it's an AI, you know, artificial intelligence, which we are using. We usually have the second spin after the surgical procedure is done. So we know that exactly what we have achieved and what we have done in the surgery. So if there are anything that breaches and can be rectified immediately, so that gives us the best of the result. We should know the dependency and the limitation which we may have because of the AI. And it is very, very comfortable in the complex cases, which we have seen over this 1.5 days, which is very important. That's what gives you the comfort. And I'm sure everyone knows the Murphy's Law. Everyone knows the Murphy's Law. Yeah, things are going to go wrong. They are likely to go wrong. So that's where, you know, we really need to have the tech friend. And this technology will certainly tame the Murphy down as well. And I would like to use 2 words here, tomophobia and tomophilia. Meaning tomophobia was the word when I started the practice as a spine surgeon in 1996, 1997. People wish to run away from the spine surgery. And now I have many patients coming to us and say that, operate me, sir. And that is the catch. That is what, you know, has made us more and more wiser. We really need to have more opinions from the neurophysician. We have the 3 checks at our institute, meaning, you know, the consulting, then we have the pre-op planning, and then we have the fellows. So everybody is allowed to speak about, so agree to disagree on the planning of the treatment as well. But that is what makes us wiser. And these gadgets have made us the uniqueness. It has given us a uniqueness. So now I'll go back to this word tomophilia, tomophobia, and that is what, I would use one more sentence here, that you are being recorded. So that is something which I would like to, cut it from my practice, that you are being recorded. I'm being recorded here. I'm being recorded by the Google, and that is something which we really need to understand, that when you are talking to the patient, you are being recorded. So, it's being followed as well. But that is very important, that we need to really, go back to my first slide now. So I'll run through the cases. There is no point in talking about the cases because we have learned a lot of things as well. This is something that the AI is going to give us, that, you have the second spin and you have this pre-operative stitching. So you can see actually what deformity correction you have. That's what the gadgets will give you. So this is very important. I'm not here to say that, the gadgets are the best. I will also share the limitations as well. So this is something which we have the third party, and we have the bone scalpel integrated. And so that is why, you can do the internal gibbous gibbectomy without, doing major posterior the destruction. And that is what we have achieved. And this is something that was published as well in one of the journal as well. And another one, non-walker. And this is something that you can get with the gadgets as well. You have the correction which was done per operative, and you can see the corrective slides as well. So this is something which you get. Again, the olive, single position, you can do only single position. That will save a lot of time as well. So you put the wires from the back, and then you have the cage to insert after preparation of the cage too. So that is something which is possible with the gadgets as well. I'm repeating the word gadget only to make sure that, the topic today has been the gadget, but something that can be done. Amit does it, Dr. Amit Jala does it regularly, the olive, but this is the single position. So that saves time too. Another one, dual pathology, that becomes a big challenge. I'm sure, the technological advances, the investigation modalities, they have given us lot more cases, they come to us. And this is the dual pathology. There was hemivertebra with infection. And you can see the correction, which you can plan on table with this gadget. Meaning, you can plan the osteotomy. And that is what will give us the overall outcome. As you can see here, that this was the correction which was achieved. So near 100% correction. So that is something which is possible. So you can plan your surgery per operative as well, like this wedge resection. And this is the post-op outcome. Another one, the spondyloptosis, no sagittal imbalance, and that was operated with the fusion in situ. So this is also possible because of delta fixation, and that was again, done very well, as you can see here. So spondyloptosis, another case, she became doctor. She was the one who came 2009, and that this echoes, the complication, if it's going to occur, it will occur. And this was something spondyloptosis, managed to do the reduction. That was 2009. And then, she ended up with the failure. After 8 years, it broke the posterior screws, and she had recurrence of the deformity, and we had to go in. And that was again, you can see that we have been able to correct, and there was L3 lysis. So, this can also, it was a sort of deformity which was going to, happening. And then she ended up with L3 to S1 fusion. Again, the nut gave way, and we ended up operating again, and then put the one more rod as well. So this is something that is possible, putting 2 screws into the iliac crest. So all this can be done with the help of the technology. So technology will give us the length, depth, diameter, and even the surprises are there. Yesterday, I think Chirayu PAMECHA also discussed about the short, the diameter of the pedicle screw when you have, and that surprise probably can be circumvented by the per-operative CT scan which you get before starting the procedure. So same thing can happen as well, congenital scoliosis. So teaching and learning has to go on, and that's what we are here. I'm sure, like Dr. Dinubhai Patel, we all should remain probably lifetime learner as well, and we all should do that, keep on learning. And this is again, as we all know, Susruta, again, we certainly follow some of his principles at this moment. Do no harm has been the Hippocrates oath, and we have been sort of saga to the best. We should be doing for the best, and luxury has converted into necessity. I'm sure the fridge was a luxury, TV was a luxury, mobile was a luxury. Now they are necessity. Same way, probably I can see the future happening with the same as well. So at the moment, Ahmedabad is struggling for the C form and BU, And that is something, which we all keep on happening too. So we will be witnessing this, I have witnessed no apron to zero radiation now. We had full apron, full radiation when I was, when you have to do the hip, you have to put your cassette and get this X-ray. That was the scenario where I was resident. We had no lead apron in the civil hospital where it was one of those, era where I was working. We had only one cautery. We had only one suction, and we used to do the surgery in the lateral position with Dinubai sir and the Harrington Road fixation at that time as well. So all those have been surpassed, and we have now, my journey has been so much so. Now I would say that our team is an enabled spine specialist team. Our place has been enabled by the gadgets, and probably we'll have the 4K 3D technology integrated as well. So that is something which is IoT SS, and again integrated operation theater spine suite. We have technology, we have the CT scan, operative, and these are the three things I would like to say. Miracle molecule is the teriparatide, which has changed the practice. Miracle gadget is the ultrasonic bone scalpel, which has changed the practice. And now probably this IoT SS, that's a miracle chamber, you can say. And that probably has given us a lot more into it, and it has saved our heart as well. So this is something, what are the benefits? Zero radiation, confidence, spinal deformity you can do. And again, minimize the infection rates. Screw breaches are identified same level, wrong level practically will be 0. And the most important thing, it will save the surgeon's heartbeat as well. Because, on table, you are able to rectify whatever, and then you are able to identify whatever problem and fallacies that you may face. So surgeon safety has increased. Standard care, maybe clinical outcome. What are the limitations? Well, I think we may end up having the dependent on the technology. So that is why, when you start training, you really have to have, is it market driven? Well, probably not. I think it's going to be the necessity tomorrow. But yes, one can really conclude that, and non-users will always say that, adequate training, equipment issues. Yes, but that is something we have to accept. So what are the limitations? Only 6 vertebrae you can see. Accuracy check is very important. When you are doing the neuromonitoring, the frame often moves. So you have to be very careful when you do that. And obese patient, you cannot see the cervicothoracic junction properly as well. So I will take 1 more minute now. I'll be finishing. So this is something where we have the surgeons team. We have divided our work. There is Dr. Shivanand does the good MISS. We have onco spine integrated as well. We have anterior spine surgeon, that is Ravi, and Ajay does the deformity and the endoscopy. And mainly I consider on the cervicals. So that is again teamwork. My message again is very clear and loud that we really have to consider the teamwork considering as well. You are responsible for what you do, but you are equally responsible for what not doing something which you should have done. This is very important message which one should take from this talk. A physician can bury his mistake because patient is not going to survive, but surgeon won't be able to. It will be seen on the CT, MRI, and the patient's neurological deficit as well. So this is something which the august crowd, we all should learn from these few words. So this is something where I would say tomophilia, tomophobia. So do not become victim of tomophilia, because that is where my younger crowd really, please understand, patient will keep coming to us. And this is something which we should never let that happen. You have somebody whom you cow and becomes tomorrow, you have to run before that participation starts bothering you. Very, very important message this slide has. Thank you for your patience hearing. Thank you. I have overrun, but I try to justify. Thank you.
Thank you, Bharat Bhai. Early adapter, integrator of the technologies you are. Thank you for that. And now inviting incoming president, Dr. Subir Bhai, a very calm person, to talk about proximal junction kyphosis. We all know about PJK. Dr. Subir Bhai, please. And I'm thanking incoming secretary for the accompanying me.
Thank you very much, Vijay Bhai. This is an August audience. I'm amazed to see that this is a Sunday afternoon and we still have a full crowd. Really kudos to Neeraj, Pratik, and the whole team who have put together an excellent show here. And I would like to start quickly. We are a little short on time. So I agree with what just Bharat Bhai just said, that spine is totally unforgiving. It is like a boomerang. Whatever you throw comes back to haunt you. So we have been seeing this, the Addison segment degeneration in the lumbar spine, and then we began to fix it. But over time, as our instrumentation progressed into the thoracic spine, we began to see the same phenomenon occurring at the higher level, what is basically now termed as proximal junctional kyphosis. So in order to understand what is PJK, we must understand the concept of proximal junctional sagittal curve. It is basically the angle that is subtended by the lower end plate of the UIV with the angle of the superior end plate of 2 levels above the UIV. So that is your PJK. And whenever this the PJA is above 10 degrees, and when it is more than 10 degrees, then the pre-op. That is when it is called a proximal junctional kyphosis. The incidence, although quoted between 20 to 40, actually ranges from 17% to 61%. It is that high. And 2/3 of these PJK are going to present in the first 3 months. Remember, the first 3 months are when you have to start identifying your PJKs, and 80% will be there in front of you by about 18 months. So the risk factors can be divided primarily into 3 categories: surgical, radiographic, and patient related. And I'm going to take the strategies, prevention strategies simultaneously for want of time. So whenever you do a dissection of the supraspinous, intraspinous, ligamentum flavum, or the facet joint capsules inadvertently, you're disrupting the posterior tension band. Any UIV in the upper thoracic spine is also considered a risk factor for posterior tension band disruption. So in those cases, you have to be very meticulous while you're dissecting at your UIV. You have to preserve your facet joint capsules, and addition of Mercilin tape, which actually is not so commonly available. And as discussed with Neeraj, he uses ethibond sutures. So that can be added to the UIV and the UIV +1 to protect your soft tissues. Anterior surgery itself has been considered a risk factor for development of PJK, but it is debated in the literature that how can it happen? But this has still been shown that anterior and posterior combined surgeries have a 3 times risk as compared to only posterior surgeries for performing, for developing PJK. Again, all pedicle screw constructs have been notoriously shown to develop increased PJK. So in order to have a softer landing, what is recommended is using transverse process hooks at the UIP level. And also what has been shown is that not tightening your last 2 threads at the post proximal UIV pedicle screw is also reduces your PJK. Using transition rods with thinner and tapering rods have also been shown to reduce your PJKs. Choosing an UIV in the upper thoracic spine usually puts your fixation at a risk of ligamentous disruption, ligamentous PJK, whereas using it in the lower thoracic spine is more likely to induce a fracture, a compression fracture, and lead to a failure. LIV in the sacrum or the iliac crest will lead to again an increased PJK and maybe a proximal junctional failure as well. The upper thoracic UIV or thoracolumbar has also been shown to be slightly increased. So choosing your levels is actually very important. No matter what you choose, the possibility of PJK still remains very high. A degree of correction is also considered. If you have a high SV and you are doing a high degree of correction, or there is a greater correction of the lumbar lordosis, both have been identified as a significant independent predictors. And so the correction has to be optimal as per the age of the patient. Certain radiographic risk factors, we just saw that increased SVA, increased thoracic kyphosis, overcorrection of the lumbar lordosis, a greater difference between the thoracic kyphosis and the lumbar lordosis, as well as a retroverted pelvis. These have been noted as indicators of increased risk of PJK. Also, what has been shown is that if there is proximal junctional angle at the upper levels near your UIV is showing a greater than 5 degrees of angulation, try and include those in your fixations, and so that you can prevent a PJK. Patient-specific factors are very common. Elderly patients, obesity, osteopenia, smoking, and comorbidities have been shown to increase PJK, and we should encourage our patients for weight loss and to quit smoking. Now, using prophylactic vertebroplasty at the UIV and UIV +1 levels has been shown to reduce the PJK from 19% to PJF actually from 19% to 0% in one article. And what other authors have showed is that if you do a vertebroplasty at these 2 levels, then there is a 13 times less likely chance for you to get a proximal junctional failure. So what is PJF? PJF is basically a PJK with structural failure of the osteoligamentous structure at the UIV and the UIV plus 1. But Yagi has defined it very simply. Any patient of PJK requiring surgery is PJF. And the compression fractures at the UIV or the UIV plus 1 are almost comprise 56% of the total amount of PJK. 35% have an osteoligamentous disruption and only 9% have a screw pull out at the UIV. We are all aware about the spinopelvic parameters and we have seen them for last 15 years. So the impact that these have on the PJK is that if there is increased thoracic kyphosis, if the PI is more than 55, or if the change in the lordosis is more than 30, then these will lead to an increased PJK. We have all learned that the ideal sagittal alignment requires an SVA less than 50, a PT less than 20, and a PI minus LL difference around 10 or less. But the larger pre-op SVA and the greater correction again leads to increased PJK. So is overcorrection a problem? Probably it is, which is why we must aim to do a little undercorrection than what is considered ideal, especially in the elderly patients. So goals of spinal alignment would be to correct it according to the age, optimize the BMD, an SVA of 40 instead of 0 is what is being recommended currently. A PI minus LL should be actually in the positive range in elderly patients with osteopenia. Patients with increased thoracic kyphosis or greater SVA prefer an UIV and try to cover the thoracic kyphosis and go up to T4. And cement augmentation at the UIV and the UIV plus 1 may help as well. General recommendations: lesser soft tissue dissection and destruction at the UIV, extend fusion levels to include levels that have a greater than 5-degree kyphosis. For a soft landing, use hooks or transition rods at the UIV, lesser implants to reduce the stiffness of the construct. Try to achieve optimal spinal balance and post-op alignment. And I must acknowledge my 3 colleagues for having shared their cases. Thank you very much.
Thank you very much, Dr. Subir. I think we will conclude this session, and I would like to invite Dr. Amit Jhala to take the stage.
I would like to call upon Dr. J.P. Modi, Rutvij Bhatt, and Piyush Mittal to come on the stage as a panelist. And Dr. Jhala, sir, please come here and start your presentation.
Please. So we are coming to the last session of this mega event on deformity. And I always tell that which is the best rewarding surgery in spine surgery, whether it is disc or deformity. For me, I would always say that deformity is the most rewarding surgery, and the patients who will always remain with you forever are the patients who are happy with the deformity. But the reverse is also the same. What is the most disheartening surgery in spinal deformity is the spinal deformity. Because if any problem occurs in this spinal deformity, the patient who has come walking to you, and if the patient goes as a paraplegic, then it is the worst thing that you will have a nightmare. And you will also have a sleepless nights for days together. And that will get imprinted in your brain forever. Because I have seen these deformities from last 20 years, for more than 20 years. And I can count and I can, all the patients I know where I have failed. And that is at my bottom of my heart. And I'm really feeling that has happened. So what I'm going to show is not the good things, but what is the downside of the deformity. Because till today morning, we have seen majority good things of the deformity. But I have just a collection of cases, which of course there are a lot of collections. I'm not going to present all because it's a case-based panel discussion and we are short of time. So I have to just rush through the cases. Okay. So coming to directly to the cases, it's in 2016, this patient presented with a D11 hemivertebra, and just I'll just throw a question to the panel. Yes, Jigar. Female, 9 years, D11 hemivertebra. Whether this is going to progress or not. That's where we always want to know and counsel the patient when the patient comes with hemivertebra, whether it's a progressive or not. And how do you define that this is going to progress?
Usually ask the patient if this is the first X-ray, first CT scan.
This is what I have the first X-ray.
Okay. So thoracolumbar junction with the 11 hemi. This patient is going to progress. I will ask the patient to come for regular follow-up for initial because this is pre-menarchal. So once the patient will reach menarche, is obviously going to progress further.
Why do you say it is going to progress? Because there are so many hemivertebras which are there on X-rays.
Because this is a
Does every hemivertebra progress? Yes, JP. Sorry, Dr. Modi.
So incarcerated hemivertebra, balanced hemivertebra on both sides won't progress, but this is junctional
Fine. So
level.
very, very important message for that. The incarcerated ones are not going to progress, and hemivertebra on the opposite side, they are going to balance each other. And so they are not going to, or they will progress, but they are in a balanced phase. So you are not going to, you may not require any intervention.
This,
okay.
This patient definitely it is junctional level, D11 hemivertebra. D status, I don't know. Basically, we don't have MRI.
Right.
But I think it would progress at
Fine.
junctional
So
level
the
and
things
need
that
surgery.
he has given are the right messages. I'm just moving forwards because we have lot of things to cover. So according to him, it's a dorsolumbar junction, and it's an open disc at both the ends of this hemivertebra. So it's going to be a progressive deformity. So now we just go ahead. So this is in 2017. The same patient came with an increased deformity. And you can say that it is collapsing at DL junction with a 50-degree of scoliosis. But more important is that these hemivertebras, they come for a kyphosis much more compared to a spinal deformity, which will produce a scoliosis. So you have an 88 degrees of kyphosis. Yes, Piyush, how are you going to manage this patient?
Sir, as the kyphosis is progressing and the age, 10 years age, so we can give a functional brace to the patient and wait for the riser signs and the age. We will go for the correction. How much is
so
the
you
bending
feel that bracing is going to work? We have a documented progression of the deformity at a DL junction with an open disc of the hemivertebra.
So we'll go for the various bending films and all that, that how much can be corrected if we go for a stretch film.
Okay. So this is what I have at present. So this is what I have at present. I don't have the bending films, but I can just give you the progression. Rutvich, anything, any input?
I will be little
because
more,
this is going to be a, yeah.
I will be little bit more aggressive. I will offer surgery at this stage because.
Okay, so what type of surgery? Because we are going for a complications rather than
hemivertebra excision and fixation.
So what type of, how many levels? And what will you do? Whether you will always remove the hemivertebra or you will just fix
Usually,
inside?
sir, I prefer egg-shelling type of procedure and somewhat like closing.
So in this
wedge.
case, for how many levels? From where to where?
At least 3 levels above and below.
So 3 levels above and 3 levels below fixation.
And somewhat like an closing opening wedge type of with.
And you will always do a hemivertebra excision, or if you get a correction, good correction, you will do an inside to posterior fusion.
At least somewhat resecting some part so that it becomes supple and.
So very important is what part? Because what part of the hemivertebra needs to be resected?
Mainly the pedicles and the facet.
And the facet. So I'll just add on to you or add on to it, because hemivertebra correction, the hemivertebra progresses at the disc because the growth plate is at the disc level. So unless you remove the upper and the lower disc, even if you correct it, it will become something like a correction, but the growth potential is still remaining, right? So that's what would be. So this is what was done by the surgeon. So any comments from Ajay? Any comments on this? So that's why I asked you. So this was the deformity, and that is the post-op. So it has got a good coronal alignment. It has got a good sagittal balance. That is okay. So he might have missed, this is not my case, but surgeon might have missed that pedicle. So
simple construct. That is the only thing I would say maybe against it.
Okay.
Otherwise, everything seems to be fine. And the rod at 10 years, this is a 3.5 rod.
I don't know what rod this is the patient presented to me.
Yeah, because
I have not operated this.
So this is a zoomed out X-ray. Likely it is a 3.5 rod, and for this pediatric, when you are compressing, these rods don't hold much.
Okay. So I do agree with some of the points that one thing that this patient, they did not remove the hemivertebra. That's the first thing, because the primary growth potential has not been cleared off. So that is one thing. And the second thing is that the fixation points are, according to me, slightly lesser. That's what I think Rutvich told, that you should go at least 2 or 3 levels above and 2 or 3 levels below. And in the, at least on the concave side, you should have more anchors, where here the concave side, the anchor is very, very less. So it's only one anchor there. So it's going to collapse on the concave side. Okay. So whatever the best was done by the surgeon for this. Unfortunately, this patient got infected also. Unfortunately, this patient got infected also. There are long dressings. The implants were open. Skin grafting was done with a rejection, and this went on for about 1 or 2 months, and the patient had a secondary healing. Okay. So if infection occurs, I think this is what the surgeon has done the best to manage at that point of time. But now what happens is, so this is 6 months. The wound is healed secondarily, but it is still holding the implants. Okay. This is 5 months, and this is 1.1 year. That means 1 year post. So there is a progression. There is again an implant impingement to the skin. So how are you going to manage? Again, coming back to Dr. Modi, now it's your turn, because it's going to increase the difficulty level, and you are an expert.
Can I have a clinical image?
I don't have a clinical image because I have not operated. So whatever I have is the X-rays.
We don't need to treat X-rays, but sir, we need to see local area. What about the?
So this is the history that the patient gave.
What is the condition of the soft tissue there at the local level?
So the patient said that there was implant impingement. The skin did not break down, but it was impinging, and there was a progression of the deformity. You have a documented again a progression of the deformity. So
Yeah,
whether
this
you
is-
are going to accept this progression or you are going to intervene.
It's not acceptable, sir. At least we have to remove these implants, and we have to
Okay.
plan something else. We have to
Okay.
fix it.
So I take your point, and the surgeon was, because the patient had an implant impingement, the surgeon removed the implant. The surgeon removed the implant. So again, a question to Dr. Piyush. So now, how will you predict whether it's going to progress or whether the patient is going to be happy?
So still the,
Because the patient had no skin breakdown, it was just an implant impingement, and the surgeon removed the implant.
so still the hemivertebra is there.
Still the
So
hemivertebra is there.
So the chances of progression are still there, sir, because it will grow and it will lead to the increase in the deformity. So we have to intervene with again refixation and the adequate removal of the hemivertebra. That will correct the deformity.
Okay, so the plan would have been removal of implant,
Refixation,
refixation.
removal of the hemivertebra.
Okay.
And then
So
the
that's a
fusion.
very, very important point that I wanted to make, that once you remove the implant in a deformity, either because of impingement or anything, in a young child, that is going to, because it has not fused, it is definitely going to progress, and the progression is going to be faster compared to what it was without an intervention. And this is what has happened to this patient also. This is now 6 months post removal of implant. So now, how are you going to manage? So that was done because of removal of implant, but the patient is still with you in March 29,
But
2019.
still, I believe that this is the growth spurt second already started.
Yes, patient is now
It's not because of
13
removal
years
of
old.
implant.
Patient is 13.
So we can go for a fusion, sir, correction and complete fusion of the posterior column with a removal of the hemivertebra and correction of the deformity with 3 levels.
So now, how long you will go and how long you will come back? So what is the upper end vertebra? What is the lower end vertebra? And what procedure?
Already D9 and 10 has been used previously for the previous surgery.
Mhm.
So we may have to go 4 level above and at least 3 level below with stronger cobalt chromium rods and remove hemivertebra and correction.
So 3 level above means you will be at
4 levels above.
So can you just pinpoint one at what level? 3, 4, 5, D3, D3, 4, D4, 5,
D5, D6, D5 or D6.
D5. And what about the lower anchor?
So that was in up till L4 week. L4
Okay.
we can go because that is a
Okay.
apical.
So, and then after doing the upper and the lower anchors, what procedure? It's going to be the osteotomy, or it's going to be just stretching out?
We need to remove the make a wedge in the lamina posteriorly, go through the pedicle, remove the whole body, upper and lower disc, and then gradually try to correct by shortening on the convex side and rotation and all of the manuals.
Okay. So again, it will require a refixation and probably the osteotomy and correction of the deformity. So now the surgeon still waited, and this is what happened. So this is how the patient is in February 21. So now what procedure? You can see that in 1 year's time, the deformity from 60 degree to 90 degree to 135 degree. And that's how the patient has presented to us. Yes, Subir? Yeah.
I think we are not left with any other option but to proceed with surgery. What is the current age of the patient?
14.
14
13
years.
or 14.
And
maybe around 13 or 14.
I don't know. The reserve sign is not much visible, but she probably
0.
Still 0.
Still 0.
Whatever. I think at 14 we may have to consider at least putting her into a traction film and see how much we can achieve.
So
with
these
just
are
a
the
traction.
flexion extension views, bending views there. The top.
She's quite correctable. So at least.
Yeah, that scoliosis is correctable, and that is the kyphosis.
So research 0 is a bit of a question, whether to do a temporary growth rod something and then hold her while.
Temporary growth rod, I think.
Or
Is
just
there an
go ahead and
option
fuse?
for a temporary growth rod at 13 years?
Or otherwise just go ahead and fuse her and do
So
whatever
we have
final
to go
correction.
ahead and fuse the
Fuse
spine.
her.
Okay. So now the surgeon also thought that I
Result
cannot
zero.
avoid a surgery again. So the surgeon went in again. So this was the cord, and you can see the cord is touching the pedicle absolutely at the pedicle level, and that's the deformity. This is the first clinical picture that I have. Okay. So considering all that, so operated in December 21, and during the surgery, there was a signal loss. So if there is signal loss, the surgeon counseled the parents in between the surgery and did an in-situ fixation because there was no signals. They counseled inside the surgery, outside the theater, and the patients told that we don't want to go ahead with the surgery. So this is how the fixation is now.
So this was after putting the screws or in steps of
I don't know. But this is what. So I think the surgeon has taken the right decision at that particular time, that whatever the best, because we don't require to give a paraplegic patient back. So, and the patient and they both were counseled. So they did an in-situ fixation.
With loss of signal, it should be reversed.
So it has not reversed anything, but I think they have just contoured the rod.
Yeah, but scoliosis, it is elongated.
Yeah.
Yeah. The pedicle was already kissing the cord,
Hmm.
and you have given a cantilever there. Definitely the cord is in stretch.
So there are so many maneuvers that you need to do. So what are the checklist that when you get a loss of signal, we will discuss that part also here. So what are the checklists that when you get a loss of signal, what should be done? Just for the audience. Yeah.
First of all, you have to take the anesthetist into confidence and take the neurophysiologist into confidence. Everything is right on your part. So the anesthetist would improve the BP. So the hypothermia is not there, that should be maintained. So certain steps not to get into hypothermia, that has to be followed, including body cooling or warm salines and those things. And if the signal loss is there, you have to consider giving a steroid there. And the neurophysiologist checks the global drop or not, and the change of leads, all those things are checked. That's it.
So mainly check of leads, anesthesia has to increase the blood pressure. Hypothermia needs to be corrected. And
hope everyone knows the BIS value.
Yeah, so
that is very important. Everybody should know that.
So yeah, what you just give it, no, because BIS 0, I'll just give you BIS 0 and BIS 100 is patient is totally awake, and BIS 0 is that patient is totally under anesthesia. So if you want a good monitoring, neuro monitoring, the BIS has to be around 18 or 20. All right. If it is around 18 or 20, then you will get a very good response. Yeah, please.
Yeah.
You can just.
Everyone knows BIS value, na?
BIS actually needs to have the brainlets and the different multiple leads. But what right now we have only the
it's an EEG,
yeah,
actually.
It is more of EEG. So it's not the true BIS what most of us have right now.
So anyway,
it should be integrated into the IONM. It should be integrated. That is very important.
Yes.
Yeah,
You have
if
to
you are-
integrate it
yeah,
because
if you
that
are-
will give you the depth of anesthesia.
That's right.
So if you have a depth of anesthesia which is higher, you will not get the neuromonitoring signals. If it is in lower depth, you will get a good neuromonitoring signal.
We have had incidences, where anesthetists have been naughty. Yeah, he will give the paralyzing agent, and then we suddenly realize, and then we'll all just look at the BIS value.
So actually, I'll tell the everyone that this neuromonitoring is not actually the IONM. It is an anesthesia monitoring.
So
how efficient is your anesthetist?
Typically, we normally used to give a paralyzing agent during exposure so that you don't get a lot of muscle contraction.
Yeah.
But in these kyphotic patients, I don't even do that because in kyphosis, even with positioning or with exposure, you can get loss of signals.
Absolutely.
So it is very important to remember that
So-
even during exposure, do not give if you're doing a
Not
kyphosis.
even exposure, you should have a good baseline.
Baseline.
You should
Baseline in
always
supine.
have a very good baseline.
Baseline should be in supine, make prone,
As well
again
as in
take a baseline, then only proceed. Otherwise, it is very problematic.
Okay. So, so this is what was done. The story doesn't end here. So now the patient came 3 months post-op. Neurology was normal. Not recovered. Patient was normal.
So that was a false positive.
So that was a false positive signal. The patient was normal, right? So again, the patient got a skin breakdown with this implant. So Rutvich, now what should be done? Convex implants exposed with impingement.
Any X-rays available? Okay, I think it wouldn't have progressed.
This is the X-ray.
If
I think again we have to go for, as the implant is exposed, we have to go for the removal of implants, and again just brace the patient and try.
So your take is removal of implant, yes?
I would go for that thing. You have to remove the implant. Skin condition is not good. Thick, very thin pad there. Whatever you do, it is going to give way unless and until you correct it completely.
Okay.
Unless and until you correct this angulation deformity, you are not going to get soft tissues there.
Okay.
It is going to impinge.
Fine. So
One more thought. Can we remove the unilateral only rod and keep the screws and other rod intact, and then?
So there are two options that we have now. According to one, that you remove the whole all the implants, and according to you, you just remove
This rod only.
this rod of
And
one
we
side,
Keep the screws and other rod intact over there.
the screws and the other rod intact. So that is what we have got two options.
I would go for another option.
Yes.
Do a plastic surgery there. Retain this. This rod is still inadequate to hold this implant. Another rod needs to be in. So if we can go from the left side and put another rod with new screws there, and the same sitting from the left side itself, go a thoracotomy, put palisade fibula, put expandable cage there, connecting from change the SVA. You have to change the SVA here. So that is the lesser thing you can do. If you want to do the all-out procedure, that is you need to do a VCL. That is obvious.
See the
But
skin condition basically. You
No,
cannot
so
do
no,
anything.
What he says is, you go from the left side, you go transthoracic, you accept this inside to fixation, you do an anterior fusion, you do an anterior fixation, and remove the post, or do a plastic procedure for the posterior implant.
yeah,
Am I
but
right?
you need to add one more rod probably, because it's still to unite, it will take some time.
Okay.
The
So
rod is
that's the
less.
third option. Okay, so that's the third option. So I think that was one of the difficult options that everyone would have, because transthoracic, it's difficult for kyphosis.
This can be addressed by LACA also. You go by the same approach, left side rod, where you have to put, you expose only the left side, and from the left side you go there, you put a incision further, because it is kyphotic already. You can excise the rib. You are changing the SVA. You can use the rib if it is big enough thick. Otherwise, take out the fibula, put it. If it's affording patient, put an expandable cage.
Okay. So for no, it's all inside too. It's all an
Inside too, no?
vision. It's all an inside. So okay, now we go forward again. So now what the surgeon did, I'll just so this is what he did, what Jigar told. So Jigar was right. So this is what the surgeon did. So he just removed the convex rod and did the closure of that thing. So that's what has been done. So that's the fourth surgery that the patient has undergone for this deformity. Now what? What do you feel? How it's going to progress? Yes, Neeraj. this is what, any inputs from any of the panels or anybody.
So the implants are going to break.
So these implants are going to break.
They will give
and
way.
they are going to fail. So Jigar, you did not think of that before?
Thought that, I thought that I give the patient some brace. I asked
So
the
I
patient-
think Ajay was much better, that you should have done an anterior fusion before removing the implant.
Yes.
Yes, Dr. Taraj. Okay. Yeah, that is point taken, but actually the first surgeon tried to correct it and did, but he should have done a better job. He should have done a better job at that time. So that's what he did. No, he did not. No, he did something like a both side fusion. Okay. So we move forward. This is how the patient is now. So this is in May 2022, 123-degree deformity, which is progressive. And this is a skin condition. Yes, you all wanted to see the skin condition. No, you were dying for that. So this is what the skin condition is, and it's a progressive, again, a deformity. Just progressed. Yes, Dr. Modi.
Patient, what surgery, sir?
MRI showed you, no, in between. No other thing. There is no other thing. So that's, should we move?
CT scan.
So what patient came to me and we planned a 2-stage surgery in this. So this is what the first stage we did. And you can see a complete sheet of bone, which was there, totally fused. But there was also pseudoarthrosis. So unless you just fuse that, this is going to progress. So there was a pseudoarthrosis, which was very well seen. So this is what we just put all the anchors first. We evaluated where is the pseudoarthrosis, and in second stage, we closed down. And this is what we went in the second stage. And you can, if this works. This doesn't work. Okay, anyway, so there is a pseudoarthrosis, there is a gross movement that I wanted to show. There is a movement, and you can see that there is a pseudoarthrosis which was there. And then we went anterior, we removed the pseudoarthrosis and did a complete VCR type of a thing. And this is what the correction that we could get it. Okay. So from 123 degree, we got a 59 degrees. No claps. Story continues. This is May 22. So it is now. So the story continues. Got a Klebsiella infection. Wound opened up and again implants got exposed. Now this is a situation that I have to face.
Just do debridement, leave the implants and whack dressing. Nothing more, sir.
Okay. Yes.
Multidisciplinary approach. Infection specialist, plastic surgeon. Take his opinion.
Okay,
Can he go for any rotational flap?
You are right.
Rotational flap.
I took the opinion
Yes.
before entering inside. I took the opinion of a plastic surgeon whether I should intervene in this skin condition. He says that no problem. But unfortunately, this has happened.
No, now, sir.
Now.
You can call plastic surgeon. Can he plan some rotation flap from somewhere? We don't know. I don't have any knowledge about this thing, but
Yeah.
we usually call plastic surgeon and we take their opinion. Can we cover up this thing? Infection can be controlled with antibiotics, IV antibiotics for 1.5 months
Okay.
through central venous line. But I think needs coverage of the implants because you have done good
Okay,
correction.
fine. This is immediate post-op and this is maybe 10 days or 15 days post-op.
Yeah.
15
Because
days.
the fusion that we have done, it is still not united completely. So there is no point that we can remove
So
the
you cannot
rods.
remove the
We have to
implants.
protect.
You cannot
So,
remove
yeah,
the
the
implants.
only
It
way
needs
is
a
debridement
protection.
and vac.
Okay. So this is what I took the advice of Dr. Modi. And a plastic surgeon is intervened here. And what he did was a very nice job. And he just did a thorough debridement. And he measured the defect and did a rotational flap. And this is what a good skin cover was given to the patient with a skin graft at that flap area. Okay, so this is how it was closed. So the message again is very, very important that you should have a multidisciplinary approach. You should always take the help of the plastic surgeon if this happens, because these are not, again, if I leave this, the patient is going to again come with a deficit sometimes. Okay. So this is what, it's a 3 months post-op of the same patient. Patient is walking at present, everything is fine. There is no infection. And so that is it. From there it is up to this. Okay. So we move on to another case, because if you have time, one more case. Quickly one. So just to complete this. So I'm giving one more case of an adult deformity now. Just one pediatric was discussed. We'll go for an adult deformity and then we have 15 minutes time for this. Okay. So a male 53 operated for L3445 laminectomy before 6 months for left lower limb radicular pain. And the patient came back to us with a recurrence of pain 2 months post-surgery with a right lower limb claudication and a weakness on the right side with tibialis anterior grade 3 and 4. And the patient already had hypertension. Angioplasty was done in 2002 and sarcoidosis and was on steroids. This is what I'm talking about in July 2007. Okay, so that's the time that this patient presented to me. So this is what was the initial X-ray, L34 stenosis, L45 stenosis, and the patient underwent a laminectomy. No X-rays were done. So the patient came to me with this position after 6 months of the first surgery. What would you have done, Jigar, in the first case?
In the first case,
Just one quick answer because we need to finish fast.
Primary fixation.
Huh?
Primary fixation.
So primary in L34, L45, you should have done a fixation. Why?
The facets are near, so I consider as a constitutional narrow canal.
So facets are sagittal and there is a disc degeneration and you can see a vacuum sign in the this thing. So primarily this should have been fixed right on the first day. So the patient was not fixed, the patient reappeared and now the patient has come with a disc prolapse at L34 and there is a degenerative listhesis at L45. Okay. Yes, Rutvich. Yeah, so there was a slight disc there. There is a degenerative listhesis. Yeah, already skipped. But this patient did not have an X-ray at that time. Came to revision.
Yeah.
Okay.
straight rod is usually not recommended. Even at that time also, you have to factor in the lumbar lordosis. So straight rods were never recommended.
Right.
Even before the surgical parents came into existence, people used to still contour the lumbar rod even for a single level, not even two level, single level rod.
Okay. So these are the posterolateral fusion, whether it will work or not. That was a doubt, but this patient had got a posterolateral fusion. Now, as if the patient comes to us, we will have an interbody fusion. All right. So of course, there is a scope for lateral fusion, but that time there was no lateral fusion that we had. Okay, 3 years post-op. The same patient came back to me after second surgery, left anterior thigh pain, 2 months, again standing time, walking distance, FNST positive, and knee jerks. So somebody was telling me that whether this is going to work. So this is what the patient has come with. Yes, Dr. Modi. Now it is a complicated case. First time laminectomy, second time 2-level fusion, posterolateral. It has fused. Posterolateral is fused. Now there is an adjacent ligament segment problem.
Flexion extension views, X-rays.
I don't have a flexion extension views of this patient. This is 2010. I just બધું ખોદી ખોદીને કાઢી છે.
Sir, age કેટલી છે મેં જોયું નથી આગળ.
54, 55, 56 now.
56. Any other medical problems? Parkinsonism.
He has got a angioplasty, sarcoidosis on steroids.
No. Presentation. Parkinsonism.
Not yet.
Sir, again, adding to the thing, sir, steroid intake, that is important thing in such patients because many times they present with AVN of the hip and that also presents with anterior thigh pain.
Okay.
So patient on steroids always look for the screening of hip joint also.
Okay.
Because restriction of hip movements are there. Initial phase of AVN, they present with anterior thigh
So
pain.
point well taken that you have to screen the other joints also. For the anterior thigh pain, the patient had the anterior thigh pain. But believe me, the patient did not have, so that has to be screened, the point very well taken.
I think again you have to go in and decompress then if it is the problem.
So you have to do a decompression with what?
Fixation.
With fixation.
Yes.
So what type of fixation you will do? Same.
Posterolateral.
Posterolateral, same.
That will also suffice.
So that will also suffice. So extension of fusion was done. This is what we did, an extension of the fusion. Is it okay? Just to finish again the case. 5 years post, third surgery. Pain in groin, difficulty in walking, and steady gait now.
Surprising they keep coming back to you. Usually ours disappear.
So bladder bowel normal, neurologically normal, and this is how the patient came back to me. Now you get a full length spine done.
What is he by profession? What is he doing?
He's nothing, he's just a નાની દુકાન છે એમાં બેસે છે.
એટલે કરિયાણાની દુકાન છે પલાટી વાળીને બેસે.
Nothing, he's not a heavy worker. He's not a heavy worker.
Sir, little bit out of box thinking. If we feel that the lower levels have already fused, okay, I would just remove that implants.
Yes.
And do decompression at the upper level where there is adjacent segment and put a dynamic stabilization.
Put a?
Dynamic stabilization.
Okay, so very good thought process. At present, what is the stage of dynamic stabilization? I think dynamic stabilization again is not working as on today. So,
but at least, sir, with that soft landing or what we say, it
yes,
will be little bit
Subir.
more.
I have experience of one dynamic because I had a similar case who kept on doing. So at that point, I did a decompression and did that hybrid thing where lower down it is a fused from globus, and then there was a high mobile dynamic on top.
Yes, Biren.
So 6 years he has still remained.
collapse. L23, there was a stenosis adjacent level. At that point of time, I would do only a fenestration decompression and go. I would not do a.
So what he
fixation.
is telling at this stage, you should have done before.
Before. Now, if this stage.
Now
again,
at this stage, what?
Yes, again the fenestration decompression, and the previous X-ray, if you see.
Now it is two levels, L12 as well as L23.
Yes, definitely.
There is a stenosis. So you will do a laminectomy or what?
I will not do a laminectomy. That is what I'm telling.
L12 and D12, L1, you will have an unsteady gait with.
There is no instability there at present point of time. I will not create a unstable segment which was created at 2-3 by doing a laminectomy. I will preserve the posterior elements from the very beginning.
You will do a bilateral fenestration.
Yes.
You will do a bilateral fenestration.
Preserving the facets. And
I think, let me ask Dr. Bharat Bhai, what will you do? Because you have the largest experience of these things.
Yeah, but I think we'll have to go up.
So you will have to go up.
We'll have to go up because if you look at the facet, I think you have to.
They are all sagittal facets.
Yeah, I think you have to go up.
I think we should remove the lower implants, do only L1, L2 fixation.
And I think the most important thing which we are forgetting, and I think that has to be given, lifestyle modification. That is very important. But at the same time,
lot many patients with lysis at 2 level and adjacent segment degeneration above that without any fixation.
But if patient
lot
is,
many cases like
agree,
this.
if patient is symptomatic and worsening, then
This patient is worsening.
yes. So I think we'll have to go in.
No, there is no problem. The patient is very sedentary lifestyle.
I think patient is thin and lean, thin and lean. You know.
Yes, Hitesh.
I would like to focus that go from below to T10 as well as simultaneously doing PSO at L3 level and achieving some lordosis and to cover whatever flexible DL junctions is involved. So maybe T10 or T9 level should go and then.
So we have got three options now. We have got three options. One is just a decompression. The other is extension of the fusion. And the third is an osteotomy and correction and getting the lordosis. Okay.
No, I think I will agree to what Hitesh said. You know, means yes, you have to stabilize it. That's what I'm
So
trying
you
to
have to
say.
stabilize.
You have to stabilize and try to. Yeah, you have to.
At what level?
2015 now.
So you are. So at what level?
You already know the parameters since last 10 years now, because they were described in 2005. Right. So now
I
we
think
know
Anil
them,
bhai,
right?
this is.
So you should correct the lordosis now.
This is the classical case where everybody must remember Rosales classification. This is a low PI case.
Exactly.
You really
No,
don't
this
need
is not
to
a low PI case.
This is
the patient came with
even
vertical sacrum.
so this is no what I'm trying to say is this is a low PI now at this present. So you have to really get back to this original Rosales classification of where you want to achieve.
So this is what I think Ranjit also presented.
Correct.
That you should have a best lordosis at L4-5
Yes.
and L5S1 to get
So
this
60% lordosis you should make it sure that you achieve at 4-5.
So fine. I agree with that point. So this is what was done and this is what the parameters were. The lordosis in this patient was 18, but the PI was very high. PI is not less. PI was very high of this patient. And the lordosis, so PI mismatch is 44. So this is what is the PI-ILL mismatch of this patient. Okay. But this is all retrospective thinking. Fourth surgery was done. Okay. And it was just an extension from D11 to L5. That is a stabilization. Okay, that's the stabilization which was done.
Story continues. Story continues.
Okay. So we do agree that in 3 years post-op, patient came with a myelopathy. Patient came with a myelopathy. Yes, now Dr. Modi. Now we have got that thinking process that we need to restore the PI, we need to restore the lordosis, the PI-LL mismatch. So how are you going to progress?
You have to operate because patient has UMN lesion.
Amit bhai, one another thing which is noteworthy is again, if you follow Ruzoli's classification, the inflection point every time has gone up.
Yes, because you are making it more and more straighter.
Correct. So
The
every
inflection
time,
point, you can
so
see that
the
there is a
previous
kyphosis
surgery,
which is developing
yes,
at
previous
the upper.
surgeries was coming up to L1, L2. Now it has gone, inflection has gone to D12, D10,
Yes,
D11.
so that's what is happening. So it is falling off, falling off, falling off. Yes, Hardik. So again, the question remains the same, whether to do an extension or whether to do only decompression. So these are the two options. So how will you proceed? Because every time that is the same thing. So I will just move fast. So I do take the point that the same thing is not going to work because we have done it for 3 times and it has failed. Every 3 times it has failed. But now, Dr. Modi, you are right. This patient came with a Parkinsonism now. So 64 years now, with a sarcoidosis, steroid, angioplasty, hypertension, diabetes, Parkinsonism. Okay, with a thoracic kyphosis only 5.4, 42.9 is the PILL. Lordosis is only 18. So now you have to optimize the patient in every way. Now you have to optimize the patient in every way. Yes.
So does that mean that inherent increased hypertonia of Parkinsonism may be adding some muscular forces
Agreed.
to the patient's recurrent problems?
Agreed.
Is
we
this
don't know.
what, because he had picked it up very early.
That's what I'm telling you.
And
all these
right
complications,
now,
we
no,
know.
so this is something that is very important for all of us, because we see Parkinsonism quite a bit in this age group. And if this is a potential risk factor for getting recurrent PJKs, then it has to be considered.
It has to be. And that is already written in the literature that Parkinson's will give a more, any muscle imbalance is the cause for PJKs. So, yes, Piyush, how are you going to proceed now? Rutvij, you can take the question. So you can see now it's a completely, even the thoracic kyphosis is gone and it's
Already myelopathy
flat.
is established. We have to go above, sir. Again, we have to correct the kyphosis and the lordotic curve to get a good balance.
I'll just move forward because we have only 40 seconds left. So this is what the whole, I'm just giving you the whole. So pre-op lordosis was 38, post first fixation it was 16, then it was 18 and it is 18. And every time the lordosis has decreased. And the PILL has always remained 40, 44. That's what the PI. So we require a lot of planning for this patient. It's not a simple case. Now it has turned a very complicated one. So we require all this optimization, surgical planning, intraoperative execution needs to be perfect. So what we did was SurgiMap planning for the osteotomy. And we planned in osteotomy at a lower level because I wanted a 3.3 fixation. I would have gone one less, then I would have got more lordosis. But I wanted a 3 fixation points. And then we planned this thing. And we did a PSO. And we got not a very good correction, but we got an adequate lordosis at that time. SVA has been corrected. Lordosis we could get was 34. And thoracic kyphosis also we could achieve a little bit of thoracic kyphosis compared to that. And this is now 5 years or 4 years post-op. And you can see this patient, Dr. Modi, this is the patient. He doesn't do anything. Here it is. So,
Came back to you. That is important.
So that's the latest follow-up that I have. Thank you.
Thank you, Amit bhai. So we are almost, dot to the time so far. We plan to start our valedictory at 1:35. Thank you, Amit bhai, for giving 2 extra minutes to me to finish off. So just last session before we go for lunch. Lunch is almost ready. Before we begin the valedictory, I would want to announce our new EC, which was selected yesterday in general body meeting, and we would have kind of a felicitation and medal giving to them. We'll take 5 minutes with that. So may I request our outgoing president, Dr. G.D. Tharadra, to come on the stage and welcome the new president, Dr. Subir Javeri. Please give him a big hand. Photographer. Sir, wait, photographer. This is a valuable memory. Thank you. Thank you, Tharadra sir. Thank you so much for everything and guidance. Subir bhai, you will have to stay. Unfortunately, Ajay has gone. He had to go for some. So I think maybe, somebody from Shivanand, you can receive the medal on behalf of Ajay, please. Ajay is our new vice president, which will be taking place of Dr. Subir bhai. Subir bhai, you will still have to stay because Ajay is not there. So the new joint vice president is myself, so I'll have to go ahead. Thank you so much. Then comes our new secretary, the medal of which I'm trying to find. So I think my bag much. No, I got it. So the new secretary which will be taking the baton for me is none other than another Modi, Hitesh Modi. Hitesh will welcome our new joint secretary, Dr. Rakesh Lohana. May I request our outgoing treasurer, Dr. Mayur Wala. Mayur is out. No, Mayur, you will have to hand over to the new treasurer. Mayur, please. The new treasurer is Dr. Jigar Aranjiwala. So we have another 5 EC members which will be receiving their certificates for being the EC. So next would be, I would welcome Dr. Bharat Dave to announce the most awaited quiz award.
Sorry. My question to all, are you all ready to see the answers of the quiz? Then we can just have the quick run through. Shall we have the raise of hand? Yes. Are you all ready? Okay. Why don't you come, Miran, then? Why don't you start? The winner team is Civil Hospital. So let's have the... So congrats to the civil teachers as well. Yeah, BGMC. Civil, BGMC. BGMC. Civil BGMC, BJ Medical College. They performed very well at the end. It was 225 marks. So the second team is with the 140 mark, that is Jamnagar. They are the runners up. Thank you, sir. And third team, they are the VS. They performed with the 100 marks. They did very well, but then they lost into the second round. And the fourth was the Surat one. Let's have the presentation. Shall we? We'll give the award after. Yeah, you can.
Yes, so the answer to the first question was D, type 4. Triple major is type 4. Campbell's triangle is dorsolateral aspect of the intervertebral disc. The Goel-Harms technique is B, fixation of the C1 and C2. A 17-year-old male DEXA scan. So you look at the Z score, which is more than -2. McNabb spur is the traction spur, which is D. R equals n square plus 1. This is a formula for biomechanical weight bearing due to curves. So R is the resistance bearing capacity of the head. N is the number of the curves. So we have 3 curves. So the total goes to 9. So the head has 9 times more capacity to weight bear.
So that is what has been discussing all throughout sagittal balance, which is very important. R is equal to n square plus 1. One has to really remember that, we need to restore the sagittal balance. That's what Amit's wise, 2 cases as well. Carry on.
This is interleukin 17 inhibitor. Erectrospiny, so the iliocostalis is a part of the erectrospiny group. So post-op infection, CRP has normalized and ESR is improving. That is resolution of the post-op infection. Signs for cervical radiculopathy. So that is Sperling sign. Asia impairment B, that is C, that is incomplete sensory and complete motor. Highest modulus of elasticity, that is cobalt chrome amongst the options. This is again Brown-Sequard syndrome. Left side it is pain temperature, right side it is motor loss. So Brown-Sequard. This one, the answer is multiple myeloma. Atlantodense interval is again A, distance between the odontoid and the anterior arch. Thoracic disc herniations, again junction of the middle and the lower third. The posterolateral disc would be L5 nerve root. Greater occipital nerve exit at the occiput C1. So A is the answer. This is the ligamentum flavum, which is shown. And the last one is the double crush syndrome, that is CTS plus C56 PID. So B is the answer.
Do you want to play the second? It's all done. Was it done? Yes. Second was done. The third was done as well. I looking at the presence here, I think those who have not become SAG member, I please request you all to become SAG member, because the way the team is working, I'm sure you are all going to get the messages and email as well. And let us have the close group. Let us keep communicating with each other as well. So become SAG member. Let's make the SAG strong. Let's have the winners now from the team D, that is Civil Hospital BJ Medical College, Ahmedabad. I invite Tradra Sahib, Amit Bhai. I think, please come here. Team members. One can give certificate, one can give. So I wish you all become SAG member in the coming 2-3 days. Yeah, and runners up, we have the runners up Jamnagar team. So can we have the Jamnagar team? They'll be giving certificate. Hitesh, you can give certificate to Jamnagar team, please. साहब ने बोला पची, we just thought of that. Why don't you come on this side, please? The third one has gone. Okay.
May I request Dr. Prabhakar sir to give a certificate of appreciation to Dr. Bharat Dave sir for conducting such a wonderful quiz, which was first attempt for by SAG. May I request Modi Sahib to appreciate Dr. Mirant, who has hand in hand worked with Dr. Bharat sir to make this quiz happen. So I would also want to thank my EC for helping me up this meeting so successfully. A small memento for everybody. May I again request Dr. Prabhakar sir to give a memento to our outgoing president, Dr. G.D. Tharadra sir. May I request Prabhakar sir to felicitate Dr. Subir Jhaveri sir, our outgoing vice president and incoming president. May I invite somebody from Stavya team to come and receive Ajay's. So it's my turn to take my plate from again Prabhakar sir. Hitesh Modi, again receive a memento from Prabhakar sir. Dr. Mayur, our outgoing treasurer. Who managed the money for SAG. Tarak is not there, I think. Tarak. So, Jigar, you will have to come twice. You know, can you collect on behalf of Tarak? And Jigar, you can receive your plaque also. May I request Dr. Rakesh to come up? I think, Rakesh, you will have to receive on behalf of Dr. Hari also. Dr. Hari is not there. May I request Dr. Deepak Shah to receive your plaque from your own teacher. And last but not the least, without whose hard work this conference would not have happened, I would request 3 cheers for Dr. Pratik Loda. The boy has not slept since 5 nights to make this happen. I cannot forget, sir, thank you so much, sir. I cannot forget my national faculties who, without whose presence, you know, this entire thing would not have happened. Most of them have left, but I would still want to acknowledge them. Dr. SAJAN HEGDE, Dr. Ram CHADDHA, Professor SRIVASTAVA, VISHAL KUNDNANI, Dr. GURURAJ, Dr. SHAILESH, Dr. SANDEEP, Dr. CHIRAYU PAMECHA, Dr. APPAJI KRISHNAN, and Dr. RANJITH UNNIKRISHNAN for making this event very successful. I would also want to thank the entire organizing committee, right from patrons, Dr. KP Pathak sir, Dr. RN Naik sir, Dr. Prabhakar sir, Dr. Pankaj Patel sir, who could not be present here. I would want to thank our organizing chairman, Dr. Bharat Dave, Dr. Amit Jhala. Would want to thank our course president, Dr. Chidi Thradra sir, and Dr. Subir Zaveri sir. I would want to thank our co-organizing secretary Pratik, organizing committee members Hardik Sutar and Anil Solanki for helping me out gathering more and more registrations. They spread it on social media. So this event was a hit on social media thanks to their effort. I would want to thank all my coordinators for the session, Dr. Mayur Wada, Dr. Jigar Anandjiwala, Kushal Shah, Hardik, Anil, Nisarg Parikh, Ronin Sangvi, Sharvil Gajjar, Jinil Doshi, Rohit Thakkar, Harshil Patel, Dwanit Desai, Dr. Keyur Akbari, Dr. Munjal Shah, Dr. Pratik Ishrani, and Dr. Viral Patel. Now we move on to thank our helpers, without which I would want to request Dr. Vijay Sata sir to come and announce the winner for the best paper award. So best paper, SAG is committed to provide the registration of either ICS 2022 or MISAPCON 22 to whoever wins this award. Thank you so much.
So continuing the celebratory mood, but before I announce the result, I want to congratulate the whole SAG team. Neeraj, Bharat bhai, you thought of very nicely conducting the quiz involving the PG students because they are the future. And very smartly, you didn't declare the result yesterday so that they are present over here till the whole day. So, excellent planning, sir. And I know Thradra Sahib thought about this paper session. So this is really good thing. And I would request whole SAG. I wanted yesterday to be in the GBM, but since I'm not a member, I could not be present. I talked with Neeraj also. I do. Surely, sir. I'll become that for sure. Today only, not in 2-3 days. So please keep on involving general orthopedic surgeons. Because if deformities are to be treated properly in time, the crux of the story is in time, we are needed. So do keep on involving general orthopedic surgeons till the time that patient knows on their own that if at all there is a deformity in the spine, they need to go and consult the spinal surgeon. Till it is right now happening that a fracture will go to orthopedic surgeon only. They are not going to GP. So we need to reach up to there. Until that point of time, do such endeavors. Continuing with for what I have been called for by Neeraj, the best paper. First of all 9 were great. So congratulations to each one of them. But we were forced to do a difficult job of selecting only one out of them. And we found intrigued by the most by the paper. Should I declare the name first or the topic first? Topic. Great. So PVBA, the work on PVBA, the pedicle vertebral body angle, that was the real most intrigued that we found out. The work was really greatly done. The presentation was excellent. Statistics were used. It was a novel idea. Clinical applicability also is there. So congratulations to Dr. Vatsal Parmar on all the parameters. And the work that has been presented by you, your institute also needs a big clap. Congratulations. Thank you, Neeraj, for the opportunity.
Coming to the last back end of the valedictory, I would want to thank all the delegates. The full house is a dream for today's conference. So since yesterday morning, we have been seeing full house. So thank you all for coming out in huge numbers. Whatever we do, if you are not there, it's of no point. So I think big credit and loud of applause goes to all the delegates and those who are viewing us online. Everybody, we thank them from bottom of our heart. This event would not have been possible without the sponsors which we got. So I would want to acknowledge their contribution. Globus, please raise your hand. Just Globus, Medtronic India, Apex and LNK, SMPL, MJ Surgicals, Nebula, Technoshine, Torrent Pharma, Intas, Sun Pharma, Tasmet Group, SAJAN all has helped us tirelessly to make this conference happen. Our event managers, Jalak, please come forward, and Virendra. So these are the new event managers. These are, we know from GPA Expo days, now they are Orange Rose. So thank you so much for helping us out. The majestic audiovisual guys, thank you so much. You know, you really helped us. Wonderful presentation. And last but not the least, the venue organizers. May I request our Mr. Vasudev. Mr. Vasudev. Nikita. And the person who was most important, Chef Sonu, who probably tickled your taste bud and provided. Thank you so much for providing us an excellent venue, and we really thank you from bottom of our heart. So the success of this conference is credit to SAG. Any failures or shortcomings is my responsibility. Thank you so much.
Credit should be given to Neeraj, because he's the man, you know, who did this. Thank you. I think, so he's the man who really, you know, started the ball rolling, and I think that's the success. Please take seat. That's the success story goes on, and that becomes a challenge for the next coming president and the secretary as well to make it more successful and do in a bigger scale.
No, I guess I would want to say that, you know, this was not my plan. I think my seniors, specifically Bharat Bhai, nudged me towards this plan. I was really not sure whether we will be able to do that such grand scale. So I thank all my seniors to support me in every aspect, right from Dr. Prabhakar sir, you know, who left all the work, you know, is sitting here in front of us since yesterday morning. In fact, the day after the dinner he's here. So everybody has supported me. So it's not my show, it is our show. Thank you so much. And the hotel people has given us cakes, and they want all of our presidents to come and cut the cake. Tharadhara sir, Subir bhai, Prabhakar sir, Bharat sir. I think only 4 presidents we have so far. Amit Jala sir, immediate past president. Future president. No, only presidents have this privilege. So with this, I open the conference and lunch, and hopefully we depart and hope to see you all soon with Hitesh bringing up. And yeah, don't forget to become SAG members. And Hitesh is there to bring us all together very soon. The registration is available online, so you can register there.
No worries, sir. Welcome.